Chair, we are ready on our end. You can start when you're ready.
Great, thank you so much. With that then, again, it's 8:35 and I'll call this meeting of the Public Employees Benefits Program Board to order. PEB staff, if you would call the roll.
Laura Freed.
Here.
Linda Fox.
Here.
Betsy Aiello.
Here.
Jim Barnes.
Here.
April Caron.
Here.
Michelle Kelly.
Here.
Leslie Biddleston.
Here.
Jennifer McClendon. Here. Tom Verducci.
Here.
And that is everyone. We have a quorum.
Great, thank you very much. Before we go into agenda item 2, public comment, I want to, I suppose, establish the order of operations for today. I'm going to be taking a couple of agenda items out of order to accommodate a couple people's schedules. So board members, if you've got your agenda in front of you, it's going to be item 1, 2, 3, moving 4 and 5 down below 6 and 7. So it will be 3, 6, 7, 4, 5, 8, 9. So you'll want to make that note. And if you would silence everybody, all of your electronic devices that make noise, that would be helpful. I'm going to limit public comment because I think there will be quite a bit of it to 3 minutes per person. I want to remind everybody, if you didn't get to comment in public, or if you don't get to, don't have the ability to stay for the second public comment period, you can always send PEB your comment in written form. The PEB staff is really conscientious. They turn it around as fast as they get it, and believe me, we do read it all. When we're in this room, for the folks in this room, not necessarily on Zoom, it is my expectation that everybody keep their masks on. I know we all have coffee and water, and that's okay to take your sips and stuff, but the mask goes over your nose, and that includes when you're testifying, unless we can't hear you, in which case we'll let you pull it down a little bit. So with that, I think I will go to agenda item 2, public comment, and I will start with public comment here in room 4100.
Good morning. Hopefully you can understand me with the mask.
We can. Please identify yourself for the record.
Pardon me?
Please identify yourself for the
Yes.
record.
I'm Dr. Patricia Davin, and I'm going to read a letter that I submitted to the board, and then I just have a couple of comments beyond that. Again, I'm Dr. Patricia Davin. I'm a psychotherapist in private practice in Carson City. I provided services to the state of Nevada employees for over 40 years. I'm also a preferred provider for many insurance programs. I've been working diligently with Aetna Signature administrators to receive in-network provider status due to the discontinuation of the contract with Hometown Health. It is important to me to continue to provide services to state employees. I submitted my application to ASA, Aetna Signature, on May 5th. I was informed of the transition of care from Hometown Health in mid-April. I'm recognized by Aetna as a credentialed provider, but not in-network. I've been repeatedly told by Aetna that I will be receiving a contract via email. To date, no such contract has been received. I have further been unable to ascertain the reimbursement rate I may expect to receive. All phone calls are answered by a call center in the Philippines, and there is no access to the actual credentialing department. In my 43 years of practice, I have never experienced such unprofessional conduct and difficulty navigating an insurance company. My patients are frustrated and cannot get information from Aetna as well. I'm hopeful you'll reevaluate this contract. My greatest hope is that you may come to some agreement with Hometown Health and reinstate that contract. This has become an absolute nightmare, occupying inordinate amounts of my time and energy. Claims submitted for July 21 and forward have been denied due to Aetna's horrid handling of this transition. Thank you in advance for your consideration in this matter. To update you, this letter was written August 21. I signed a contract with Aetna on October 2nd. To date, December 2, I still do not have a contract, even though I received a fax, which was received into my office on the 26th of November, which I got when I came back into the office on Monday, the 29th, indicating that I'd completed the credentialing process and that a network representative would be sending me an effective date. December 2, I have no contract. So, 2 understatements for you. One is, I love my work. 2, these are unprecedented times. In my over 4 decades of work with patients, I have never seen the severity of symptoms that I'm seeing today. Anxiety, depression, loss, grief. And to compound it, my patients, many of which, had their copays doubled. For some of them, that meant that they had to see me less frequently, in a time when they really needed to be seen more frequently. So I implore you to get rid of Aetna, number 1, and 2, should you do that going forward, I would ask you to seriously look at the details of a contract of any kind from an insurance company in terms of this in-network.
Dr. David, please wrap up your comments.
Pardon me?
Please wrap up your comments so others can
Sure.
have a chance.
I would implore you to really look closely at the in-network, what that means. That is, what does it mean for state employees? What does it mean for providers? How long does the process take? What does it involve? And also, again, to look very closely at the salient features of these things. Some insurance companies have a behavioral health component. What does that mean? Thank you. I appreciate your time.
Thank you. Next commenter. Please identify yourself for the record.
Okay, I'm Patricia Elliott, and I'm a licensed clinical social worker. I've worked for 3 decades in Carson City providing private practice psychotherapy to people. And I have a large group of state of Nevada employees. Patty and I ran into each other this morning, and we both are doing something very generous, where we're providing services without a contract. We're not getting paid from Aetna at all. I actually started the process. I hired somebody so it would be expedited so I could get on the list, the in-network list, very quickly. I don't have anything. I'm supposed to be getting a contract tomorrow, but we'll see what happens. So I'm seeing, and Patty said she's doing the same thing. We're basically seeing clients for the copay right now because we know our clients do not have the financial ability to pay us. And my hope is that you will go back and reimburse us starting July 1st because it's not our client's fault and it's not our fault for what's been going on with this provider. I also feel that my hope would be that you'd go back to Hometown Health also. Not only is the mental health issue really important, but it's actually cost effective to you to provide good providers because all the studies right now are showing that if people have good mental health, they have much better physical health. And I have people that need services, and I can't provide everything for $40 an hour. So I have nobody to refer even to because there's so few people available. So thank you very much for giving this attention, and I do hope that you go into with a better insurance company like Hometown Health. Thank you very much.
Thank you. Are there other commenters here in room 4100? All right, seeing none, I will turn it over to LCB Broadcast, and we will hear from folks on the phone.
Thank you, Chair. To participate in comment, please press star 9 or raise hand in the Zoom to take your place in the queue.
Good morning. My name is Brooke Malath, for the record, and I have submitted written comments. And let me just thank you for the opportunity here to speak quickly. It's time that the PEB administration end the discriminating exclusions for covering transgender services in the health plan. Unlike some people want to believe, suffering from gender dysphoria is not a choice, but the treatment to be able to help mitigate the impact of gender dysphoria is the right thing to do for for people through an appropriate medical intervention plan that differs for each individual. We can go into detail in other areas as to what really needs to be covered. We've been talking about this now for a year. The resistance to this exclusion must stop. We are talking about a 1/100th of a percent of the cost of overall spending to be able to cover additional treatment for gender dysphoria. Why are we trying to balance a budget on the backs of the small number of people who desperately need these services? Please consider this. Please look at reversing the exclusionary language that are in the health plans that prevent appropriate treatment for medically necessary procedures for gender dysphoria. Thank you for your time.
Thank you. Next caller.
Hello, this is Kent Irvin. Can you hear me?
Yes, we can.
Good morning, Chair Freed, Executive Officer Rich, and board members Kent Irvin, K-E-N-T-E-R-V-I-N, for the record, representing the Nevada Faculty Alliance, the independent association of faculty at NSHE colleges and universities. A strong benefits program is essential for the recruitment and retention of high-quality faculty and other state employees, but unfortunately, the cuts to PEB have undercut that goal. For Agenda Item 6, the Nevada Faculty Alliance is neutral on COVID surcharges. All NSHE employees are required to be vaccinated as a condition of continued employment after the end of this year with medical and religious exemptions. Therefore, NSHE employees should be exempted from any additional requirements by PEB to document their vaccination status. Agenda Item 7 states that 26 million of the 47 million excess reserves as of the beginning of the fiscal year are available for enhancing benefits. That is a conservative estimate. The proposal to stretch those funds over 3 years is very conservative. Every biennium for the past dozen years, PEB has made plans to spend excess reserves down to near zero by the end of that biennium, but even that has never happened. Projections that are overly conservative hurt participants by forcing cuts to benefits that then become permanent. Option 3 in Agenda Item 7 comes closest to restoring pre-pandemic benefits, except for life insurance and long-term disability, and therefore is strongly preferred. The estimated cost of $11 million per year is well within the available excess reserves for FY 2023 and beyond. Option 3 should be recommended by the board, then let the governor and interim finance committee make the final decision per Section 21 of SB 459. Option 3 as amended, however, still does not fully restore the HMO EPO to 0% coinsurance, leaving it 10% or 20% for not sure which services. This should be corrected even if it raises employee premiums back to FY21 levels. Note that benefit changes to the middle and high plans do not affect the cost to the state because the cost differential above now flat employer contribution across all three plans is borne by the participants. It is important that the design for the low deductible and HMO EPO plans make the additional premiums that employees pay worthwhile to them. For FY22, the deductibles and coinsurance for the HMO EPO plans have led to dissatisfaction and uncertainty in costs. The whole idea and attraction of a high premium HMO style plan is providing certainty in costs through fixed copays. Thank you for your dedication and your consideration today.
Caller with the last three digits, 338. You are unmuted and may begin.
Good morning, Chair Fried, members of the committee. This is Priscilla Maloney, Priscilla representing the AFSCME retirees this morning. Can you hear me, Chair Fried?
Yes.
Thank you. Real quickly, I think, Chair Fried, in the interest of efficiency, what I'm going to do is just do 4 bullet points of the tracking the actual agenda items in no particular order. The easier ones, in the sense of none of these things are easy this morning. However, the more straightforward ones, I should say, are on agenda item 6, AFSCME Chapter 4041 retirees are neutral on this agenda item. That doesn't suggest that there has been a brief or sketchy back discussion. There have been extensive discussions. AFSCME International has supported that all Americans get vaccinated as soon as possible since the beginning, since the inception of the pandemic. So we are neutral on agenda item 6. On agenda item 7, again, in the interest of efficiency and also recognizing the excellent work the Nevada Faculty Alliance does, we agree and would like to piggyback on all the comments that Dr. Irvin just made and also what's in the written public comments from Dr. Douglas Unger. We agree that that option 3 most closely gets us back to pre-pandemic levels with those adjustments as mentioned by Dr. Irvin on plan design for the future for 2020 or 2023. And then finally on agenda items, because these two dovetail together, 4.2, the American Rescue Plan funds request, and agenda item 5, the executive officer report, as Ms. Rich has gone over already in advance with us, as you know, on our pre-board meeting on Monday. We are deeply disappointed in what is represented as being the governor's office position on the American Rescue Fund funding to restore PEB cuts. There's been much discussion of one-time monies, but I would remind this body that in 2020, at AB 3, the 31st special session, section 131.1 to be specific, the state government had no hesitation in sweeping PEB funds in a one-time act in direct response. That was what was articulated to the legislature in response to the shortfalls because of the pandemic crisis. So there is an opportunity here, $2.7 billion, as we all know, to restore at a bare minimum what was swept in that special
Ms. Maloney?
session. And I would certainly urge this, yes, I'm wrapping it up.
Yes,
I would just urge this body to consider that fact. Thank you so much.
Okay. Thank you.
Doug Unger, D-O-U-G, U-N-G-E-R, President, UNLV Chapter, and Government Affairs Representative, Nevada Faculty Alliance. Thank you, Chair Freed and members of the PEB Board for your service, and to Executive Officer Laura Rich for her good communications. For the record, once again, and I won't waste your time repeating other points, but we really must express how disappointed we are at the governor's apparent lack of support for restoring PEB benefits for American Rescue Plan funds. Again, I'd like to point out that the governor and legislature do not even indicate they put back the $25 million the legislature swept from the PEB budget due to the COVID-19 economic crisis, and that this is the first time in the history of PEB that such a sweep has not been restored. We are baffled as to why. We appreciate PEB Board support for our strong request to the governor and legislature to restore the PEB budget and benefits to pre-pandemic levels. Regarding the agenda for today, for item 6, the COVID-19 surcharge, as has been said, the NFA takes a position neither for nor against. We do urge all state employees to get vaccinated for personal health and for the safety of their workplace communities. For item number 7, the proposed plan designs for FY23, we urge the board to vote for option number 3, which offers plans closest to restoring benefits, lowering deductibles and out-of-pocket maximums the most to bring relief to those most in need. And if option number 3 begins to appear unsustainable because of anticipated claims, there is time to make adjustments next year. Regarding agenda item 8, the new contracts under consideration, we can't express enough praise for and even amazement at the dedicated work and due diligence that the PEB staff, Executive Officer Rich, and the board have devoted to stewarding so many contracts through the RFP process in a single year. We support PEB's recommendations. You all deserve a bonus and extra vacation time. We wish we could unwrap that for you as a gift, but instead we'll simply thank you and wish you happy, healthy holidays. Thank you.
Thank you. Next caller, commenter.
Caller with the last 3 digits, 832, you are unmuted and you may begin.
Thank you. Good morning, Chair Freed, other board members, and PEB Executive Officer Rich. My name for the record is Terry Laird, spelled Terrilaird. I'm the Executive Director at RPEN, the Retired Public Employees of Nevada. RPEN was formed in 1976, and we currently have close to 8,000 dues-paying members. The bulk of our membership is retired public employees, although we do have close to 1,000 members who are still working and who would be directly impacted by item 6.3 on today's agenda, a surcharge on roughly 5,000 unvaccinated PEB participants and about 1,600 of their dependents. Executive Officer Rich will speak on the reason for the surcharge, and you will see a letter from one of our members who's expressed a strong opinion on this matter as well. RPEN, being a nonprofit, nonpartisan organization, will not take a position one way or the other. At issue, though, is cost of the surcharge and how it will burden many public employees who are already dealing with escalating healthcare costs coming out of their paychecks, especially those in entry-level positions earning lower salaries than many of their counterparts. In addition, because of the pandemic and the impacts on the state budget, Governor Sisolak eliminated long-term disability and made other cuts to participants amounting to close to $25 million that RPEN and our advocacy groups would like to see returned to PEB through the COVID federal rescue funding that the state received earlier this year, amounting to nearly $3 billion. Unfortunately, though, as you heard in previous public comment, we did hear this week that the governor has informed Ms. Rich that PEB will not be receiving any of those federal dollars. That is extremely disappointing in light of so many other sacrifices these participants have already made. It's as if PEB, through this surcharge, is being forced to come up with its own care funds to deal with this issue that they face through no fault of their own. So we urge this board to seek other options to help cover all COVID-related costs rather than overburden state employees with more fees, and instead look toward the governor's office for relief through that federal funding received earlier this year. I'd also like to echo remarks made earlier by Doug Unger and Kent Urban relating to option 3 under number 7 on your agenda. We do appreciate this board's hard work and thank you for looking out for the hard-working state employees. in the great state of Nevada.
Thank you. Next commenter.
Hi. Hi, my name is Stephanie Parker, and I'm a member of ASME Local 4041 and a state employee with over 13 years of public service with the state of Nevada. I want to voice my dissatisfaction with the lack of progress part of the governor's office, finance office to restore benefits of the public service workers who continue to serve the communities of this state during the pandemic with the ability that they have with the funds from the American Rescue Plan. This action or lack thereof is clear evidence of the lack of respect of public service workers. This, coupled with the fact that furloughs forced upon state workers without relief for performing their same work levels, have not been compensated. A great number of employees like myself had to purchase our own equipment to work remotely when our offices were closed due to the pandemic. I share the sentiments of the previous speakers and item number 7 when you're considering the 3 options to go with the one that is less burdensome on the actual members. And that would be item number 3 or option number 3. I'd like to see the PEP board take stronger stand to restore the benefits that were taken and stop allowing them minimize the impact these cuts have had on employees who are on the front lines. Thank you.
Thank you.
Ms. Garcia, please press star 6 and raise hand, mute yourself. Sorry, Chair, please stand by as we are trying to connect the caller.
Okay, I figured we might have technical difficulties. Thanks, broadcast.
Caller, you're unmuted and you may begin. Thank you. Chair, it looks like the caller is having technical difficulties connecting. Would you like to go on to the next caller?
Yes, please, let's.
Caller with the last 3 digits, 909, you are unmuted and you may begin.
Yes, thank you. My name is Logan Kennedy. That's LOGANKENNEDY. And I'm the chapter president for the Nevada State College chapter of the Nevada Faculty Alliance. I'm here today for agenda item 7 to personally advocate for option number 3 of the revised plan designs, as these are closest to pre-pandemic plans. The current PEP benefit plans disproportionately impact those with families and those with chronic illnesses who rely on specialty medications. No family should be subjected to a maximum out-of-pocket cost of $10,000 annually or be subjected to paying thousands of extra dollars per year in premium costs with reduced benefits. As a parent to a 5-year-old boy with a bleeding disorder, I'm especially troubled by these insurance plans. My son Grayson has severe hemophilia A and requires monthly intravenous infusions to prevent internal bleeding and longer bleed times if he does get injured. He relies on incredibly expensive medication to ensure that he can live a typical life and play like his other friends without the risk of an injury. Without access to his medication, something as simple as falling and hitting his knee on the concrete can be debilitating and prevent him from being able to walk for a few days afterward. However, under the current plans, we've experienced an incredible amount of financial stress to obtain his medication, which the copays can range anywhere from $6,000 to $8,000 per month. Because these astronomical copays are not possible for the vast majority of Americans, we also have to rely on financial assistance to partially offset the medical costs associated with this. However, under the current plans, this assistance does not go toward our deductible or the insurmountable $10,000 max out-of-pocket cost, meaning that we are essentially having to pay extra through increased premiums for fewer benefits from our insurance. Managing our son's bleeding disorder is difficult enough without having to wonder whether or not we will be able to afford his life-saving medication on top of that. Now, I understand that the PEP board can only do so much with the funds they've been given, and I appreciate all of their hard work on the matter. But on behalf of my family and others in similar situations, I'm asking the PEP board to please reinstate the previous PEP benefits to pre-pandemic standards. Thank you so much for your consideration and time.
Thank you.
Caller, you're unmuted and you may begin. Caller, you're unmuted and you may begin.
Good morning. My name is Rosalie Garcia, Rosalie Garcia. In reference to agenda item 6, I strongly oppose applying surcharges on a specific group of members due to their personal health preference. There have always been healthcare costs associated with individuals on their personal health preferences. However, historical precedence has established that the PEB membership as a whole shoulder the burden or bill for the entire membership, regardless of health situation. Outcome-based health contingent programs as a part of a PEB health and wellness program have not been implemented in previous years as they were looked at and considered discriminatory and a stretch to comply with HIPAA. Perhaps I'm out of touch. Do we apply a surcharge on smokers, type 2 diabetics, obese persons due to excess food intake, persons that attempt suicide, or any of the other medical conditions that occur due to personal health choices? If not, then perhaps we should include those members in this proposal, as those types of health events have historical data to support that those expensive healthcare events can be avoided. I agree, my proposal is ridiculous, but when discussing reducing costs, it is exactly what will be required in order for PEB to ensure that membership is treated equitably and fairly, and that a specific group of members are not targeted with excess fees under this proposal. Also, why only charge non-vaccinated? I know of members that choose to test because they are fearful of being asymptomatic and possibly spreading to family or friends. In addition, many people are now traveling and testing is required. Will vaccinated members, including retirees, be surcharged for testing? I submit that the program maintenance of a monthly premium COVID surcharge would be extremely cumbersome and costly to maintain, more so than what has been projected. In addition to the continual maintenance of employee and dependent COVID records, which executive PEB employee will make the determinations regarding legitimate, religious, or health exemptions? Would PEB need to hire 1 or 2 consultants to review the exemption requests, or would the PEB board need to convene for appeal? Who would cover the lawsuits that are sure to be filed? All of these are added costs for a program meant to eliminate costs. Also, as more data becomes available, current health reports indicate that vaccination does not permanently guard against COVID-19 or the variants and does not stop transmission. Will PEB refund the fees when it's determined that all persons need to be continually tested to ensure that they too are not a danger to society? Of the available options, I sincerely hope that the PEB board recognizes surcharge as discriminatory, not consider the PEB staff recommended COVID testing surcharge, and instead say no should it come to vote. I do want to also add that
Ms. Garcia, you need to wrap up.
Thank you. I do also want to add that do not be pushed by staff to make such an unprecedented decision based on their calendar schedule. Take the time to really consider it and take the time to let this pan flush out a little more before you start charging people for unnecessary expenses. Thank you.
Thank you. Next commenter.
If you have recently joined the call and would like to participate in public comment, please press star 9 or raise hand in the Zoom to take your place in the queue.
Hello, are you able to hear me?
Yes, go ahead.
Thank you. Good morning, Chairwoman Freed and board members. My name is Janelle Woodward, JANELLWOODWARD. I'm a state employee representing AFSCME Local 4041 state employees. Our union, AFSCME, fought very hard for the American Rescue Plan to include aid to state and local governments. This was very important to our collective recovery from this pandemic that we are still in. According to the guidance provided by the federal government, ARP funds are intended to be used to restore cuts caused by the pandemic. This includes cuts to the PEB budget that were done in response to the economic impact of the pandemic to the state budget. We are extremely disappointed that the governor's office has chosen not to use ARP funds to reinstate our state employee benefits to pre-pandemic state. It is the right thing to do, and it is what those funds are meant for. The current year's healthcare benefits have been detrimental to many of my coworkers to the point that many are unable to utilize our healthcare coverage except for basic things. We receive a bill for nearly every service we get. Some are paying thousands of dollars for diabetic supplies that were low cost or free in the past. This is unacceptable with the cuts to our pay this year. Regarding the 3 proposed options for plan changes for the coming fiscal year, AFSCME supports option number 3, which provides the most benefit to all employees. We ask that ARP funds be requested to fill the gaps in option 3, allowing all cuts to be restored to pre-pandemic levels. We would encourage the PEB board to also not only support the best option for employees, but to push for what is best for employees. Thank you for all of your work and support of state employees.
Thank you. Broadcast, do we have anyone else in the queue?
Yes, Chair, we have one more caller.
Okay.
Caller, you are unmuted and you may begin. Caller, you are unmuted and you may begin.
This is Robert Burchard, last of BORCHARDT. I'm a state of Nevada employee for the last 23 years and 4 months. My comment is in regards to item 6.3. I believe option number 2 is the best for us to continue 100% coverage for COVID-19 treatment related claims. As a single income family, the hike of the insurance this last year has now caused me $4,331.76 that I have to pay now for my yearly insurance for my family. PERS increased 24%. I just lost another $20 per pay period, so that comes out to $520. This $55 a month surcharge would be an additional $660. So now I've worked for the state of Nevada 23 years, 4 months, and I'm going to be losing $1,899.64 per year. We haven't had any raises. Your state of Nevada employees that work very hard are normally paid 20 to 30% less than your city and county workers. We have a high turnover rate, according to the Las Vegas Review Journal, with 135% turnover rate in 2020. People are leaving due to pay and benefits. I believe this is going to further hurt the state of Nevada. We have less employees. Employees are being placed in immediate danger on a daily basis in my area due to short-staffed. I have some of the best state employees. Actually, I'm honored to be the supervisor of a state of Nevada Employee of the Year. That person is looking to go elsewhere, as 18 others are trying to leave also. So please do not have the $55 a month surcharge. And I thank the board for their time and everything they do for us. And I would like to also thank the caller, Rosalie Garcia, last of GARCIA. I 100% agree with her statement also. Thank you for your time.
Thank you. If there's no more.
Chair, the public line.
Oh, I'm sorry.
I'm sorry.
Please go ahead. No.
The public line is open and working. However, there are no more callers wishing to participate at this time.
Okay. Thank you so much for your help, broadcast. With that, I'll close public comment and remind everybody you can, of course, send it to us via email to PEB staff. And of course, there's a second comment period at the end of the meeting. So with that, I don't know if the Attorney General's rep for PEB is on the line or not, so I think I might have to skip agenda item 3. Oh, no, we have her. Okay, so with that, we'll go to the AG's office for agenda item 3.
Thank you, Madam Chair. This agenda item is to allow me to make a disclosure regarding conflicts of interest on behalf of the board members who are eligible for PEB benefits. Of course, most of the items on today's agenda have an indirect effect on those benefits. In particular, items 6 and 7 regarding COVID-19 coverage and potential program design changes for plan year 2023 relates more directly to PEB member benefits. So pursuant to NRS 281A.420, on behalf of the board members who are eligible for PEB benefits or whose families are eligible for PEB benefits, I offer this disclosure that they will be voting on those items that may affect the benefits available to them or their family members. The law does not require abstention from voting merely because the board member or their family member is eligible for PEB benefits. At this time, I invite any members of the board who has any additional disclosures to make those now. Thank you.
Okay, seeing none, then I will move to agenda item 6. Like I said earlier, I'm going to move 4 and 5 down below 6 and 7. So let's go to agenda item 6, everyone. All right, for the record, Laura Rich, Executive Officer of the Public Employees Benefits Program. Before I begin presenting this report, I do want to start out by letting the board know that we do have a few folks here in attendance who will be available for questions. Director Dwayne Young, he's Policy Director for the Office of the Governor, is here. And we also have some representatives from all of our vendor partners, as well as a representative from the Nevada System of Higher Education as well. I'm going to deviate a little bit from this report, at least the way it was written. There's a lot of information in here, and all of the separate items sort of bleed into each other, so I'm going to try to present it in a way that flows a little bit better than the way it's written in the report. Also, I plan to go over each option during the presentation, but since they're so interrelated, I think it's best if I go through the entire report first, and then take all the we'll take all the action items all at once at the end after discussion. So I will start with 6.1, which is COVID cost sharing. So at the beginning of the pandemic, we know that the governor's emergency declaration placed a requirement on health plans to cover COVID testing at no cost. Although PEB was not subject to the requirements of the emergency declaration, the board at the time opted to cover the COVID testing consistent with the regulation. We followed that pretty consistently, and also treatment at 100%. We discussed this at the September board meeting because the PEB staff had brought to the board the option to restore cost sharing, and after some discussion, this was tabled and asked to bring. Staff was asked to bring this back to the board at this meeting. So in that time, PEB reached out to public employers throughout the country and the state and confirmed that many of the plans out there, insurers, had done exactly what we had done. They had suppressed or not enforced cost sharing on COVID claims. However, out of 11 states, only one state, which is Hawaii, has indicated plans that they're going to, most states have actually ended that, and only Hawaii is continuing to waive the cost-sharing option. So the remaining states, plus 6 of Nevada public sector plans, as well as the culinary health plan, have ended that.
And so they've reinstated cost sharing for COVID claims. They either ended it most recently, or even at the beginning of 2021. Cost sharing for members on PEB's fully insured HMO plan offered in Southern Nevada was waived by HPN beginning in February 2020, but at the end of December of 2020, they actually returned that cost sharing as well. So as a result, there's already inconsistencies among the PEB plans. This is pretty much in line with what we've seen nationwide. A nationwide survey basically shows that 72% of the largest insurers in each state and DC, so that was 102 health plans, are no longer waiving these costs, and another 10% of plans phased out waivers by the end of October 2021. So PEB, since we have paid for the cost sharing for members and all of their COVID claims since April of 2020, which is when the vaccine became widely available, PEB has paid in member cost sharing costs about $3.2 million. And that is for out-of-pocket expenses for COVID-19 treatment and hospitalization for members that are on our self-insured plan. So remember, those on the HMO did not receive that. At the September 30th meeting, the board requested additional information regarding various cost-sharing reinstatement options. We discussed possibly restoring cost-sharing for unvaccinated members only, or maybe by age. There were several discussions. And so PEB went back to the table and we did some research, and basically we found out that HIPAA prohibits plans like PEB from discrimination based on health conditions. So basically, this one is simple. If cost sharing is restored, it must be applied to all members across the board, regardless of health status. So it's an all or nothing type situation. We restore it or we do not. So the options here are to restore cost sharing for COVID-19 treatment related claims on January 1st of 2022, or to continue the coverage that we've been providing for COVID-19, which is 100% coverage for these treatment-related claims under the declaration until the declaration of emergency is repealed on a federal or state level. So I'm going to go through, is that okay? All right, I'll go through the entire report. So section 6.2, this is where I'm going to reframe the report a little bit so that it flows a little bit easier and is more easier to comprehend. So first we're going to start with the testing mandates. I'll start with the federal mandate first because I think that it's easier to start with that and then go through the state mandates. So on November 4th, the Biden administration, along with the Occupational Safety and Health Administration, which is OSHA, published an emergency temporary standard, ETS. This new rule requires that large employers, so that's defined as 100 employers or more, administer weekly testing for their unvaccinated workforce starting January 4th, 2022. The rules here are clear that the costs associated with testing fall either on the employer or the employee, and that the decision falls on the employer as to who gets to absorb those costs. There is no indication here that the feds have any interest in covering these costs. Since then, this has been challenged in the courts, and the Fifth Circuit Court of Appeals granted a motion to stay the ETS. So this federal mandate is now in limbo until further action is taken. However, let's move to the state mandate. The state mandate, last August, the state implemented a weekly testing requirement for all unvaccinated employees. The exceptions were for those employees considered fully remote workers and those who worked in workplaces with a 70% or above vaccination rate. So, for example, PEB is located in the Bryan building. No one at PEB has had to test, no unvaccinated employees at PEB have had to test since day one because our building was designated as a building that was over that 70% vaccination rate since day one. The Division of Public and Behavioral Health secured on-site vendors to perform these weekly tests at several locations throughout the state at a cost of about $130 a test. So the numbers of employees that tested varied week by week, but the average was about 2,700 that were testing a week. And that number has since dropped pretty significantly because more and more work sites are meeting that 70% threshold. So it looks like the state is going to continue the weekly testing, and to align with the direction being taken by the White House, it is likely that that 70% workplace threshold will be eliminated. So that's leaving about 5,000 state employees required to submit to weekly testing because they're unvaccinated. Also, DPBH's contract used CARES Act funding. It is expiring on December 17th, meaning that the state will need to figure out another funding source to cover these costs moving forward. In addition, the Nevada System of Higher Education is also exploring their own testing option because although NSHE has imposed a vaccine mandate on their employees, there are a number of employees who have received medical or religious exemptions and will be required to submit to weekly testing as well. So the most recent numbers that I received from NSHE, and this may be updated since then, it shows that 813 remain unvaccinated and 341 employees have received exemptions. NSHE has a deadline of December 31st, so any employees that have not been vaccinated or received an exemption by then will be terminated. So why is PEB involved in the testing mandates? First, let me start off with providing some background on the federal requirements on COVID-19 testing coverage. Section 6001 of the Families First Act requires that health plans cover COVID-19 diagnostic testing, and we'll talk about diagnostic and surveillance in a minute, at no cost to the member during the national public emergency period. So that FFA does not require plans to cover surveillance testing. PEB is currently covering all types of testing claims. So what is the difference between diagnostic testing and surveillance testing? Unfortunately, there's not a whole lot of clear guidance on this, but surveillance testing is similar to, for example, what the state is doing, where unvaccinated workers are required to submit weekly to receive a weekly test if they have not been vaccinated. A diagnostic test is someone that has symptoms, right? So you're coughing, you've got a fever, any kind of symptom that is related to COVID-19, you suspect you have COVID-19, that is diagnostic. The difference is here that a diagnostic test is mandated to be covered by insurers, whereas surveillance is not. Most insurers nationwide do not cover surveillance testing. The problem is that there's, again, very little formal guidance on what qualifies as a diagnostic test and what qualifies as surveillance. In fact, PEB has seen only 5 surveillance claims come through our program since the beginning of the pandemic. So what I'm hearing from the industry is that insurers are having to dedicate resources to identify possible claims that are being submitted by providers that are likely surveillance and not diagnostic. So what does that mean? That means that when they see a provider submitting a claim for John Smith for a COVID test week after week after week, that is likely a surveillance test and not a diagnostic test. So providers insurers are having to dedicate resources to sift through this and identify that and push back on insurers. They're pushing back on providers, and without real clear guidance, I think it's easy to understand why this can be a problem once more and more employers begin implementing testing requirements. Given that many employees were already testing through other channels besides the state on-site option, likely using their insurance or the PEB insurance, to be tested through private providers, the governor's office and DPBH reached out to PEB with the hopes that PEB may be able to coordinate an alternative process at possibly a lower cost option to the state. So PEB's ability to leverage existing resources and steer members may help contain cost and better project expenses associated with this testing. So as PEB staff began to work with our partners to research these efforts, we discovered that billing for COVID testing is anything but simple. It can vary widely, and providers have a lot of discretion on what and how COVID-related claims are billed. Testing can range anywhere from $0 to hundreds of dollars. So what PEB discovered was that claims billed through pharmacy they can be billed to the feds through an agreement between pharmacies and HHS. Since these claims don't go through the PBM, PEB has no data on how many employees, how many PEB members have had a test administered through this option. But there's an exception to that. We also found that members who had accessed pharmacy minute clinics or drive-through testing, they were being billed through medical. These costs were somewhere in the $130 range because they included the testing and then also the associated provider visit. Then there's other options such as LabCorp or Quest, and they tend to be somewhere in the $75 range. And then there's higher cost facilities. If you go to an urgent care center or something like that, it can be several $100s for a COVID test. Finally, there's other options that are free because insurance information is never collected. So that can be options such as health district testing sites. So to come full circle, both NSHE and the state will be conducting employer testing. Neither are funded to absorb those costs moving forward. So shifting the cost onto the employee potentially opens up a loophole. Employees who are subject to pay for testing will quickly realize that seeking a COVID test elsewhere will be covered 100% through insurance at no cost to the employee because remember, providers are billing at diagnostic rates, not at surveillance, not using the surveillance codes. And therefore, those costs are likely going to end up having to be absorbed by the plan regardless. So far, the plan has paid about $3.4 million in testing costs. Again, that's just through the medical side. We don't know how many have received testing through the pharmacy side as $0 and how much that has been paid by the feds. This is not inclusive, that $3.4 million is not inclusive of the cost paid through the DPBH on-site testing contract. So delivering the weekly testing through insurance will allow PEB to control and plan for costs. PEB has been exploring other options that replicate the state's current on-site testing process, and we have several options that appear to be very viable. One option is offering an on-site solution, which is about $60 a test. And another option we're looking at explores a self-administered at-home testing service using a telemedicine type provider who oversees the testing and then logs out the results. That's about half that cost at about $33 a test. While these options have yet to be fleshed out, it allows PEB to pivot quickly and better plan for future liabilities of the program. So the options here really we're looking at, one is to deny coverage for surveillance testing. We can do that, but we all know that no one's billing using surveillance codes. Providers are billing using diagnostic codes, and until that changes, the plan is going to be really liable for all those costs that come in for testing. So the second option is to provide 100% coverage for surveillance testing only through PEB-approved solutions. So these are low-cost solutions we can steer members to and provide to better be able to plan for the cost of the testing program. And then the third option is to continue to provide 100% coverage for all COVID testing. It's important to note here that no matter what, the health plan will likely assume increased costs related to this overall increase in mandated testing, not just for the state, but other employers who want to put this into place. If people use providers who are billing this as a diagnostic test, insurers will be subject to pay for that because we are federally mandated to pay for COVID-19 claims, testing claims. So that leads me into 6.3, which is the COVID surcharges. A recent survey indicated that about 70% of unvaccinated employees would be motivated to get vaccinated if surcharges were imposed on them. Delta Airlines and several other private employers have implemented surcharges already as a way to recoup COVID-related costs on their self-funded health plans. Delta estimated that the average COVID hospitalization cost on their plan is about $50,000. In some instances, employers have reported that their vaccination rates have increased about 20% after a surcharge was imposed. PEB reached out to other public sector health plans, and while most had not implemented a surcharge of this type, many were interested and expected to consider it at some point. Those health plans that we reached out to had asked PEB to share with them what PEB discovers going down this track. So why does PEB need to consider surcharges? The original intent of this proposal was to cover increased claims associated with the treatment of COVID-19. And to be clear, that is still a major concern. Just this week, PEB had a claim come in for $500,000 in billed charges for a patient that was hospitalized from COVID, who later passed away. I've told this story before. I think at every board meeting there's several COVID stories that PEB has shared with the board and the public. This is not going away. These costs are here to stay. And yesterday, I happened to look at a report of pending high-cost claims. Those are claims that have not yet been paid and are over $100,000. And 6 out of the top 20 highest cost claims were due to a COVID diagnosis. So there's definitely, it's quite clear that COVID is a major cost driver in terms of treatment and hospitalization costs. Now we have an additional factor, which is employee testing costs. The combination of both of these potential costs put the plan in a situation where we must identify revenue sources to cover these increases. PEB is largely a taxpayer-funded plan. Outside of employee premiums, it's a taxpayer-funded plan. And since we do not have the ability to adjust the state subsidy portion outside of legislative session, we have no choice but to look at other options. The only revenue option that leaves us with is the employee premium side, right? So we do not collect additional revenue to offset. If we do not collect additional revenue to offset the cost associated with COVID hospitalizations and testing, then those costs will have to be absorbed by the plan in the form of either higher premiums for all members or reduced benefits, which in turn may impact the discussion that we have in Agenda Item 7. So to go over the legal requirements a bit, in response to the overwhelming interest on this subject, the Department of Labor recently released new guidance confirming the legality of COVID surcharges. It's similar to smoking surcharges that have been imposed by plans in the past. And they also provided a clear roadmap for health plans to use when considering the implementation of a surcharge. HIPAA prohibits health plans from discriminating against participants based on a health factor. A health factor can be an individual's health status, a medical condition, or receipt of health care. Vaccination status falls under that category as well. But despite this, HIPAA permits different premiums for participants complying with programs of health promotion and disease prevention, so AKA wellness programs. There are two types of wellness programs: a participatory, which basically uses the carrot method to incentivize a member to satisfy a health requirement. And then there's the health contingent. A health contingent program is broken out into 2 categories: activity-based and outcome-based. Requiring a member to pay a higher premium to obtain a particular health status, like a COVID-19 vaccination, is an outcome-based program. Outcome-based programs must offer reasonable alternatives. So in the case of a COVID surcharge, the plan will have to provide another way for an unvaccinated member to avoid the surcharge and pay the same premium as a vaccinated member. The most common practice here is to offer a waiver option for health or religious purposes. As for the dollar amount the plan can impose on a surcharge, there's several federal laws that must be taken into consideration. Health insurance must still be considered affordable under the Affordable Care Act, meaning that the least expensive employee only, and that's important, the employee only premium option must be less than 9.83% of the employee's household income. So since PEB and most employers do not have access to this information, the IRS provides some safe harbor rules to determine affordability. These safe harbor rules take into consideration things like poverty, federal poverty levels, FPL, and minimum wage. Ultimately, though, the surcharge is limited to 30% of the total cost of the employee-only coverage. Using this information, PEB determined that the limit for the employee surcharge is capped at $55. So we cannot impose anything more than $55 on an employee. While dependent surcharges must still comply with HIPAA wellness rules, they're not subject to the same limitations that employee surcharges are. So employers have a lot more flexibility in dependent surcharges in that amount. PEB anticipates needing about $175 for a surcharge for dependents in order to recoup sufficient revenue to offset the expected expenditures of the plan. So in this, we took some assumptions, and again, there's a good possibility that these assumptions will change. Because out of those 5,000 employees, we don't know how many will get vaccinated, how many will get exemptions, how many are remote workers who are not subject to this, right? And so there's some assumptions here that we're using. The first one is cost. So originally we were looking at the different types of testing and what we could expect these costs to come in at for the testing cost. And we're looking at probably 40, 60, 80. So low, medium, high, right? And that's based on our ability to steer members to our preferred cost options. We're also looking at the 5,000 unvaccinated state employees at the time that this report was written, the 1,250 unvaccinated NCHI employees, 95% of them being enrolled in PEB. And then we're looking at 5% surcharge exemption rate. This is based on AON internal tracking of experience using other private sector health plans. They're looking at 5% received an exemption or a waiver. And then the dependent surcharge assumes dependents 18 years of age or older. So we have no intent on imposing a surcharge on any individual under 18. So it is adults over 18, whether they're spouse or a dependent child. So if you look at on page 8, the table there, it takes a look at the surcharge revenue, what we're expecting, and the testing cost. So this really, looking at the medium here is we're looking at about $18 million that we are anticipating of expenditures related to this. And this is not including medical costs. This is just including the testing. And so through these surcharges, the 55 and the 175, the expected revenue here would be about that 18 million that is necessary to raise that revenue to meet the expenditure costs. So, like I said, it's important to know this is a very fluid situation, and as PEB receives more accurate data around these numbers, the projections and the tables may likely change. And we do have the ability in the future to make some adjustments moving forward. But we do need to make a decision today, at least to have something to go on. The following are just some of the dependencies that can greatly impact plan costs in the coming months. So the legality of the federal mandate, again, the state mandate, what we're looking at in terms of, how many employers are looking at surveillance testing, vaccination numbers, remote workers, and then also terminations. How many of those NCHI employees that are left are will be terminated on December 31st. Hospitalization costs, like I said, I mean, we've got a whole lot of pending costs out there that are COVID related. And then we have that COVID pill that is likely due to be released or approved, hopefully in the next coming months. And the cost to that could be, if the feds decide not to pick it up and insurers have to pick it up, then it could be a significant cost to insurers as well. So as more data is gathered, PEB expects to adjust the dependent surcharge amount. But like I said, we really do need to start somewhere. And this is from the data we have today that the 175 and 55 is what we're looking at. So the process, a lot of it is not fleshed out yet because, again, we're in the early stages, but PEB's new enrollment and eligibility system vendor has implemented functionality that allows employers to administer a COVID surcharge, similar to how smoking surcharges are managed. Employees would have the ability to upload copies of their vaccine cards beginning in January through the end of open enrollment in May. We are also looking at PEB has the ability to access the state's vaccination data as an insurer. And so to make it easier on employees, we may be able to absorb that data and the vaccination data. And so those who have already received vaccinations will have it on record. The system can also accept vaccination data from an outside source, so we're exploring that. Members who have not provided proof of the vaccine by the end of open enrollment would be assessed the appropriate surcharge on their Plan Year 23 premium, so that is beginning July of 2022. As unvaccinated employees become fully vaccinated and provide the proof to PEB, the surcharge would be removed. Did you? Oh, okay. And so exemptions. To meet the reasonable alternative requirement, PEB would allow unvaccinated members to submit medical and religious exemption requests. NSHE, who recently mandated vaccination among both staff and students, has already established an exemption process which requires those seeking a medical exemption to submit a form completed by a medical provider and those who may be seeking a religious exemption. PEB will be working closely with the governor's office and legal counsel and would likely establish a very similar exemption process to the one that NSHE has already put into place today. So the recommendations here are to, one, reinstate cost sharing for COVID-related treatment and hospitalization and apply existing plan rules to COVID-related treatment and hospitalization claims effective January of 2022. Allow surveillance testing coverage only through PEB-sponsored vendors. And 3, implement a COVID surcharge effective 7/1/2022 for all unvaccinated primary members of $55 per month per employee, and implement a $175 a month COVID surcharge effective 7/1/22 for unvaccinated spouses and domestic partners and dependents 18 years of age or older. So I know that was a whole lot of information. I am willing to discuss and take questions.
Okay, thank you for walking us through that. I'm going to open it up to the board for questions because I'm sure there's a lot of them. But I want to, something you said about page 8 of the staff report caught my ear, and I wanted to get it sort of on the record. In that box on page 18, we've got, using these assumptions, we've got surcharge revenue and then of $18.4 million, and then testing costs in the mid-range, assuming it's the $60 test of $18.6 million, so a differential of about $150,000 there. But we also heard that COVID treatment is a significant cost driver. You mentioned 6 out of 20 of high-cost claims. That's 30%, if I'm not mistaken. So the recommendation is to impose a surcharge on employees and unvaccinated employees and unvaccinated spouses and dependents 18 and older to cover testing costs as anticipated because we have a lot of uncertainty around testing costs, or is it testing plus treatment costs, claims costs?
So Laura Rich for the record. So quite honestly, I mean, so we're limited in what we can assess in a surcharge. So $55 is what we're limited for the employee. So we've got to pick up the rest of the cost through the dependent surcharge. Now, this is only addressing the testing costs. We can certainly add in the anticipated COVID hospitalization and treatment on this, but then we're looking at very significantly high numbers for the dependent surcharge, and staff wasn't prepared to really go above that 175.
Okay, got it. So the surcharge is to cover the testing costs. The cost sharing is to bring PEB in line with other peer health plans in Nevada, as well as large public sector health plans in other states, and from that end, tackle the claims cost side.
That is correct.
Okay. Thank you for clarifying that understanding. Board members, I want to open it up to questions.
Chair Fried, for the record, Jim Barnes. I'd like to ask a question of the governor's office representative.
All right, we'll give him a second to get to the table.
Yes. Yes, my question is, why aren't American Rescue Plan funds being used to provide the required surveillance testing?
For the record, Dwayne Young, Policy Director for the Office of the Governor. So first, thank you, Chair Fried, and to the board for the opportunity to address the board and answer questions directly. Answering Mr. Barnes' question, American Rescue Plan's funds have been used for the surveillance testing for the last 4 months. The state put in about a $20 million investment in state employees to make sure that, one, we were being able to function properly, have meetings such as this, and be safe and secure our workforce. Since then, we were looking at about a 50% split of employees who were unvaccinated. Since then, we've seen an increase of 5,000 employees who became vaccinated as a result of this vaccination and testing surveillance policy. What we know is that the state will continue investment through ART funds in standing up testing across the state. Because, as Director Rich mentioned, the Biden plan has been stayed, but the state is still supportive of that and knows that testing needs to spread in support of many other entities, including some small businesses who may not be able to take this on. And so there will be a continued investment of that. But we would like to, as Director Rich has pointed out, one, it is quite cheaper for PEB to cover it than the state through ART funds. And for every dollar of ART funds that we spend on these things, it's a dollar that's taken away from housing, childcare, and many other initiatives that we've heard from the over 4,000 submissions into the Every Nevada Recovers Framework portal.
And just a follow-up on that, why haven't American Rescue Plan funds been used to restore the funds that were swept from PEB due to the pandemic?
Again, Dwayne Young for the record. That's a good question. One of the reasons is the Treasury guidance has not been final. And so we are waiting for the final Treasury guidance. But as you know, during this special session, it was determined that the calculation of what lost revenue was. However, those funds have since been transferred, and actually there's an IFC subcommittee today that is overhearing those items. And so we have recognized that one of the things that we have to do, I am a 14-year state employee, 6 in this state, 8 in another. One state in which I've only received one raise my entire career. And so one of the things that we've recognized is that we have to do something for state employees, particularly through the last 2 years that state employees have worked extremely hard, been flexible, and sacrificed many things, and our salaries have not kept up with the pace of the private market. We know this. We have to do this in a way that, one, is sustainable and does not drive us to a fiscal cliff. And so the hesitancy that you've seen in ARP funds and restoring the PEP benefits is because we have to be able to understand where we're going to be economically as a state. We've seen the recovery of Nevada, and we've been very cautiously optimistic, particularly in the gaming revenues being over $1 billion each month for the last several months. And so we hope that continues, and we hope that we're in a better position. But one of the things is we cannot put ourselves in a fiscal cliff where we restore benefits and then not be able to sustain those in 23 and further drive state employees from the state. And so what we are trying to do is, one, focus on what kind of package and what better benefits across the board can we put together for state employees to entice them to stay, to entice others to take on a life of state service without putting the state in a position by doing it now where we've already closed a budget to reopen it and reconsider restoring those benefits. And so I understand that people need relief now, and I hear that. And I myself, I look at that situation and I understand when I've had to switch providers. I understand that, but we have to do it in a way that is both economical and smart and looks for the future of building the state. And so that's why we've been cautiously optimistic about doing anything like that.
Thank you.
All right. On the other side of the dais, I thought I saw Member Kelly and Member Ayala, maybe Member Carmen. So I'll take Member Kelly's question, and then after that, Betsy, if you wish to go.
Thank you, Chair Freed. Okay, so my questions don't specifically put you on the spot anymore. I appreciate your testimony. I guess what we've heard overwhelmingly during public comment, though, is that employees are being squeezed now. We heard from a supervisor of employees that all of his employees are looking to leave. And so with our legislative sessions that only meet every other year, what the due diligence you're doing is costing is potentially all of our high-flying employees. So then when the state finally reinstates our compensation and benefits packages, we've already lost the good employees. They're hard to get back, right? It's going to be an incredibly competitive labour market. It already is. At NSHE, we're having trouble hiring people today. And so I guess that's the challenge you're tackling now, but we're also tackling it every day, and we hear it from employees. So, as I say, thank you for talking about that. I just hope that maybe it can be fast-tracked a little bit so that we can keep our employees. Because training and recruitment is an expensive endeavour. So thank you. Okay, so I actually have a question for Executive Officer Rich around the, I guess, more focusing on the COVID surcharge at the moment. You talked about how this is kind of to recoup costs. And so I just wanted to, I don't totally understand why, if we're doing this not as a punishment but to recoup actual costs, why would we not have the surcharge apply to everybody who's unvaccinated, including minors, because the vaccine is available to children from 12 and up. But also, why would we exempt people with medical and religious waivers? Because they still are costing the plan, right? They're still getting tested, they're still potentially incurring costs at hospital and stuff. So that's really my question. Thank you.
So Laura Rich for the record. So the recommendation is to not impose surcharges over for dependents under 18. However, we can certainly change that if that's what the board would like to do. As far as your second question and the ability to give an option for waivers, that is by law something that we would have to do. That is ensures in the definition of how we can impose surcharges. We have HIPAA and ACA and Department of Labor, all those rules that have to be followed, and there are very clear reasonable alternatives that have to be offered. And so that reasonable alternative is the most common practice is to offer an alternative for either religious or medical reasons.
Sorry, just to follow up, but isn't the reasonable alternative the vaccine?
it's the reasonable, Laura Rich for the record, it is the reasonable alternative to the vaccine. So it is, you can get vaccinated and not have the surcharge, but you have to have a reasonable alternative to not receive the vaccine and not receive the surcharge. So that reasonable alternative is the medical exemption, and that's why NSHE has that as well. Not for the same reason as a health plan would, but it's for similar reasons.
Thank you.
Member Aiello?
For the record, this is Betsy Aiello, and again, I have a question for Laura Rich. And my question is just understanding one of the sentences that is how we can allow to do the surcharge. The statement says it's the health contingent broken into two main categories you talked about, and the outcome-based, requiring a participant to pay a higher premium to obtain or maintain a health status. It's hard for me to understand how that higher premium would be the surcharge for not, unless it's to maintain not having. It just sounds almost backwards to me, and I know that it's probably been reviewed by legal, but I was hoping to get some clarity. Thank you.
Right, so Laura Rich for the record, right. So it's a requirement the requirement is to be vaccinated. And so that's the health contingent requirement, right? So that is the outcome based. And so the requirement here is in order to not receive the surcharge, you must be vaccinated. So you have to offer a reasonable alternative to that outcome. But so does that make sense?
Sort of. As long as it's reviewed by legal and everything's okay, then sometimes legalese is hard. Thank you.
I saw Mr. Verducci's hands up, unless Member Biddleston, did you want to go? Please go.
Thank you. Leslie Biddleston for the record. I have a question regarding the surveillance versus diagnostic testing that Member Rich or Executive Officer Rich talked about. It seems very confusing that we have had this pandemic for a long time and this virus for a long time, and we can't figure out what the difference between surveillance and diagnostic is. And if we can somehow have like a surveillance test for those people that are testing weekly, that may have costs, drive costs down a little bit for testing, because looking at page 8 on these testing costs, it's just incredible. So that's kind of a comment. I don't know if it's a question, more of a comment.
Laura Rich for the record, I can address that. So just to be clear, surveillance and diagnostic, and I can't say this for sure because I haven't seen the cost, but our TPA is in the audience, they can confirm. They come in, basically the cost is the cost, regardless of, what kind of test you're getting. So, if it's a rapid test, it's at one cost. If it's a PCR, it's at another cost, right? And so the cost is not different, whether it's surveillance or diagnostic. The difference is it's a code. It's how it's billed. And so the insurer we are federally mandated to pay at 100% a claim that comes in with a code that is diagnostic, whereas a surveillance, we are not. So a claim that comes in with a code as a surveillance test, the insurer is not obligated to pay. The problem is the provider community, and this is something I've heard from other health plans, and it's been confirmed across the board from conversations I've had from people in the industry, that providers are largely billing everything as diagnostic. And so when these claims come in, insurers are obligated to pay these claims. So the difference is not in cost, it's just how it's billed. and whether we're obligated to pay or not.
Mr. Verducci?
Yeah, thank you. Tom Verducci for the record. I wanted to point out that when I start my workday, I'm required, when I go out in the field, to meet with anybody, I have to be vaccinated, and I'm asked questions how I'm feeling today, if I've had any exposure, and it's a very effective way of reducing the spread of COVID-19. And, I see that NSHE has implemented vaccine requirements, and the OSHA, Department of Labor, is requiring employers with over 100 employees be vaccinated come January 4th. And even though there's pending litigation, I think that it is required to have some kind of plan in place to reduce the unvaccinated membership and the exposure that the plan will be paying with increased costs and expenses. So my question would be for Mr. Young, what is the state of Nevada's plan with the OSHA and Department of Labor requirements come January 4th?
Dwayne Young for the record, and I just want to clarify, yes, the OSHA plan didn't require vaccination. It required employees who are either be vaccinated, and if they are not vaccinated, they be tested weekly. The only portion of that plan that is a vaccine mandate is for providers who bill Medicaid or Medicare directly through the federal government. They must, and so that's large healthcare systems, hospitals. A few providers are exempted, such as schools, home and community-based providers, and physician offices. But that is a large portion of the medical community. That has had court challenges which have not succeeded, and so that is still in motion. With the Biden plan or the OSHA plan being stayed, the state of Nevada has already been in compliance. In fact, we were one of the leaders in the nation in doing this by implementing our vaccine or testing policy. The difference between our plan and the federal plan is that we said once a work site achieved 70%, and 70% was based on the known available science that we had at the time, that moved us closer to a herd immunity. We've since learned more that is closer, because viruses tend to mutate, as we've seen, and with various variants as they grow stronger, as less people are vaccinated. And so we know that needs to move closer to the 90% mark. And so our policy said 70%. Where we will be moving is all unvaccinated employees. So those who previously had not been tested because their work site had achieved that 70% will now have to be tested in compliance with that plan. And so the White House this morning, as I was driving here, has announced new plans to really push this. But the focus is really, one, get people vaccinated. That is the most safest and effective way to stop the spread of this disease. And for those who medically cannot be vaccinated, or it is against their closely held religious beliefs, then we pose the alternative of protect those and everyone around you by being tested. Know your status weekly. We've had this conversation, and it's not any different than what we've had in public health for years, whether it's STDs, whether it's tuberculosis, whether it's chickenpox. Know your status, be tested, and protect everyone around you. And so this conversation has not become any different. I think some of the politicization around this particular subject has made it a bit more intense. But when we get to the core of it, it's common public safety measures and protections. And so in summary, to answer your question, this state will continue to lead. And so we will continue to test unvaccinated state employees. What we are asking you to consider today is to help relieve some of that burden on the state employees by covering it through the plan. By doing that, by having a surcharge on those who do not choose to be vaccinated. There are many people who feel strongly against being vaccinated. They won't do it. And so, but this pandemic has been shouldered on the burden of everyone. And now, the testing should be shouldered on the burden of those who refuse to do so. And then finally, in asking in asking all of that, it's simple. It's not a punishment. It's not a retaliation. It's simply saying we have to move our state forward. We have to reach the road to endemic. We have to find our way out of this. And the way out of it is either be vaccinated, and if you're not vaccinated, be testing, and have a way to understand that you will be surcharged to cover that testing at a cheaper cost than the state taking childcare resources, housing resources, food security resources to pay for that testing.
Wait a minute. Is there a follow-up from Mr. Verducci?
I'll go ahead and pass.
Okay. Mr. Barnes, do you have a question?
Yes, for Mr. Young. As I understand it, you said that it's cheaper for PEB than for the state to do the surveillance testing. Did I understand you correctly?
Yes, that is correct.
Okay. Is that because the state is not funding PEB to do the surveillance testing?
That is because PEB is a health plan and can leverage mechanisms as a health plan that the state cannot.
So I guess what I'm getting at is it an unfunded mandate then? Is that what we're talking about here?
Yes, it was, and that's why the state put in initial resources, because we wanted to protect the health and safety of our workers, and so the state put in the initial resources for testing to get us there, but we knew that it was not long-term sustainable, and so we looked through other mechanisms such as health plans. The same as Medicaid covers it, the same as Culinary Health Plan would cover it for their workers, and many other private plans would cover it that are employer-based.
Okay, thank you.
Member Kelly, would you like to? Okay.
I actually have a question that kind of switches the gears a little bit, and I wanted to actually, so there's basically 3 recommendations on the table from Executive Officer Rich. And I wanted to maybe run through my notes. The first, I think the first choice is around the cost sharing, or the first vote. And so one of the statements you made was that the board either consider going to the cost-sharing model effective January 1st, or not going then and then waiting until the emergency declaration ends. That's kind of extreme, right? Because you're talking about making a change to our plans mid-plan year, which I always have issues with. Couldn't the board choose to go to the cost-sharing model on July 1st of 2022 when our plans update?
Laura Rich, for the record, we can certainly do that as well, yes.
Okay, thank you. My next question is more around the process for the waivers, because I think we've now been talking, or we've heard about waivers for maybe 3 meetings. So this is the 3rd meeting. I think we talked about it at the last one. You'd mentioned it at the one before. So I'm somewhat concerned that you still don't have a process flushed out. So we're here today talking about actually potentially putting in a COVID surcharge, but we've really got no idea how it would work. And that's a concern to me, because I think that process is everything in health insurance, and that's often where participants get the most frustrated with us, is where we outline kind of a goal, but we don't have a process flushed out. So can you talk a bit about why we don't have a process flushed out, and when you expect to have that in place so that the board can review it?
So Laura Rich, for the record. First, I'll just say there was a lot of work and research involved in just to get us to this point. And so the work and effort involved to come up with a process will also be a process in itself. So we wanted to take this in steps. It made sense to take it in steps, not do all the work that's associated with flushing out all the details unless the board made the decision to move forward with this. So while we do have high-level details in place, I've made sure that our enrollment and eligibility system vendor can accommodate any of these recommendations. We've had all of those initial conversations with public health in terms of getting the vaccination data. We're already starting behind the scenes. But for example, the exemption process, right? This is something that PEB needs to work very closely with the governor's office and legal counsel to ensure that the exemption in that waiver process. We are following the legal requirements and really meeting the coordinating with the governor's office to ensure that we're aligning in our path forward. This does not go into place. It is not implemented until July 1, and so we have time to implement the details of that process and move forward with that. This is something that I plan to bring to the board in January and in March, and again in May. We'll be talking about this at each board meeting moving forward. So it's definitely, as we get more details, like I said in the report, there's a lot of initial data that we're working with that we have. But if that data changes, we'll have to come back to the board with new information and say, for example, let's say that the 5,000 employees, it looks like now we're down to 3,000. Well, that changes costs. That changes a lot of criteria. And so we can come back to the board in January or in March and say, look, maybe the 175 was too much. We can probably bring it down to 100 or whatever it is. So we have time to flesh out the details, but we need to make a decision today so that we can move forward with the actual plan itself and start with the implementation and move forward with those things.
This is Betsy Aiello, and again, this is for Executive Officer Rich. I'm going back on to something Michelle had just mentioned, and that has to do with restoring cost sharing for COVID-19 and the date possibly to start or not start. Actually, by the board not imposing cost sharing on COVID, we are actually operating outside our current plan design, correct? Because the plan design itself requires cost sharing for certain things. And we just said in a vote, oops, I'm sorry, I'm Italian, I have to use my hands. In a vote, we decided we were going to operate outside the current plan. And then you also said that when, because of some things the federal government had said at one time too, and we decided to elect to do it, but our health plans, such as our HMO, did that for a while and they've reversed it. So our own programs are a bit operating in disaccord also, I think. So I just wanted to get back to that because it's not really a plan design change. It's implementing something, though people maybe have gotten used to it, though. My guess would be that if you haven't had COVID and been in the hospital, you may not even realize that the plan is paying 100% because you haven't experienced it. I don't know. We know it. We're sitting here, so thank you.
Correct. And Laura Rich, for the record, it was a change that was made in mid-year when we made this exception to the COVID cost sharing. So COVID is treated differently than any other disease today in the cost sharing aspect. And so it was done mid-year. It is something we can change mid-year. It is something we can change, in July if that's what the board would like to do. The recommendation is January of 2022 because, as you said, we already have a misalignment within our plans because the fully funded or the fully insured HMO plan, those members are not receiving, so they're paying cost sharing for any COVID-related treatment, whereas those on the self-funded plan are not subject to it. And we are also, with the exception of the state of Hawaii, one of the only public sector health plans that has not reinstated cost sharing for COVID.
Can I just ask a very quick follow-up on that then? So I hear what you say. So just one clarifying point. So COVID is not discussed in the plan document, and there's no reference to the differential treatment of COVID in the plan document?
I am not, for Laura Rich, for the record, I am not 100% certain. I'd have to go back and really get through that master plan document. I'm not the one who updates it every year, but I will definitely, I don't believe that was added. I will have to look at it specifically.
This is Laura Freed. That's not my recollection that we changed the MPE to account for COVID. And, I have to say here, piling on what Betsy had to say, I don't really enjoy the idea that we would treat participants, who do the same job in the South and who are a member of the HPN HMO, has to pay cost sharing if they contract COVID, as opposed to somebody in the North in the same job class, making the same money, who gets their claims paid at 100%. And that is why I'm in favor of reinstating cost sharing to treat COVID like any other disease. But anyway, I'll leave it to other members with questions. Oh, Ms. Fox, go ahead.
Linda Fox for the record. So I have a quick question regarding testing. So if we chose option 2 to provide coverage for surveillance testing, only on-site employee testing, it would still allow for a loophole, right? So I guess this question is for Laura Rich. So you could still go anywhere and say you had symptoms and that would generate a higher cost, correct?
Correct. So Laura Rich for the record. So let's say that an employer decided to push the cost on to the employees, and an employee was subject to, let's say $50 a week to be tested. The loophole here is that insurers are required to pay for at 100% a test that is a diagnostic test. And so, playing devil's advocate, I'm a unvaccinated employee who is subject to weekly testing, and I know that I have to pay $50 a week to test and through my employer. But I know that if I show up at the nearest CVS and cough and say I've got symptoms, it's paid at 100% for free. So how long do you think it's going to take an employee to realize this and say, well, if I go to my employer and I'm subject to the $50 out-of-pocket expenses, but if I go to CVS and get the $130 test that's billed to the insurance plan, then I pay zero. So that's the problem there, is that until industry-wide we can figure out, and maybe CMS is going to potentially come out with much more stringent or clear guidance on the definitions of surveillance and diagnostic testing. But we're not there yet. The providers across the board are billing as diagnostic and not surveillance.
Betsy Aiello for the record again. Executive Officer Rich. So the question that I have is that I understand where that could happen, and over time there might be some development of surveillance, but by doing an option 2, it would build a process, from what I understand that you said, and also Mr. Young, that we might be paying $60 a test instead of $130 a test. And I, as an employee that had to be tested if I'm not vaccinated, it would be a whole lot easier for me to go to the site right near my employer. It would cost PEB less. So even if someone could still go to CVS and pretend it's diagnostic, we're developing an easier option than number 2 would be, I think.
Laura Rich, for the record, correct. We're actually exploring a very viable option, which is using a telemedicine provider where we have actual physical tests that we can distribute or mail to the employees, and they, using a telemedicine provider that is virtual on their phone, they self-administer the test. The screener on the other end will then log the results in, and so state staff have the ability to see, okay, this person tested and is negative, and so we will have that information. So that's even, you know, you don't even have to show up anywhere. You've got a test that you can self-administer at home. So yes, and that's exactly what we're saying. It's, you know, about a $33-ish option for those tests. And so we can, by offering that, we can control costs, we can contain those costs and steer members into using that instead of using the $130 option, or even more expensive if you go through urgent care or something like that.
Mr. Verducci, go ahead.
Yes, Tom Verducci for the record. Do we know what the associated costs would be for exemption requests as well as vaccine documentation, and what the process would be to review the vaccine documentation? Is there a process in place?
Laura Rich for the record. PEB is actually looking at that. We are working with the Division of Public and Behavioral Health to potentially access the vaccine data that the state already has access to. And so insurers already do get that, as well as other organizations and entities that have been granted access through statute, to access that information. So we would be getting that hopefully electronically anyway. Now that's just state data, right? So if you've received your vaccination, say in Texas, then we don't have that. And so those members that we wouldn't have access to their state vaccine data, then we would allow them to upload through the eligibility and enrollment system vendor. They would upload their vaccine card, just like they upload their birth certificate or their marriage certificate when they enroll into PEB and they enroll their dependents. It's similar to that. And so that's how that would be. We see that process happening.
And Tom Verducci again, would there be an additional cost to the program?
Laura Rich for the record, no, that is built into the eligibility and enrollment system, and we have that ability to, it sounds like, again, we're transitioning to a new vendor on January 1st, and so this is a new vendor, but it sounds like it's part of that system, and just, something that can be just turned on, and it's a function of the system.
Thank you.
Michelle Kelly for the record. So just a follow-up on recommendation number 2. How long, when would that take effect? So obviously there's a process involved in selecting the vendor and stuff. When do you anticipate, if that was passed, how long would it take to implement?
Laura Rich for the record, we are already exploring those options. We've had a lot of conversations already. It sounds like there's a several week runway for that, but we expect, because it is through existing vendors that we have in place already, we don't have to, there's not a lot of contractual work that goes along with it. And so we're able to kind of pull the trigger on that pretty quickly. I would say within the next 3 to 4 weeks, we could make it happen.
And I'm not sure, sorry, Michelle Kelly for the record, I'm not sure who this question is addressed to, but is there a required process for notifying employees around kind of if we start to limit the vendors? I know that they're used to having on-site right now, but they're also used to being able to go to CVS and stuff. So is there a 30-day or a 60-day notice period that we anticipate?
We would definitely, Laura Rich for the record, we would definitely be communicating this, not just through PEB, but through the Department of Administration, through the governor's office. We're also working very closely with the Nevada System of Higher Education, who is not part of the state process in terms of the on-site testing that we've provided for state employees, but moving forward, because they are part of the PEB system, I've been working very closely with them as well to secure options through the university system as well. And so we would be communicating this as much as possible. Again, we're looking at, potentially being able to mail these tests to people's houses or distribute them through the workplace. And so I think this is going to be a coordinated effort between agencies, between the state and the university system. So there's going to be a lot of communication that's going to need to happen.
Thank you.
Mr. Barnes, did you have a question?
I just wanted to clarify then, is it true that there's a 30-day notice required for any change of coverage? Maybe that's a question for the Deputy AG, but...
Laura Rich for the record. So there's yes, but this wouldn't really be a change in coverage. It's not a benefit, right? So this wouldn't qualify under that.
Okay, because that was my concern, that if it is a change of coverage, it couldn't be done by January 1. And so we're sure it's not a change of coverage then?
Correct.
Okay, thank you.
And I do have to say, Laura Ridge, for the record, I did receive a response. Member Kelly, I have actually a former staff member text me just now and say that, yes, it is. The COVID-19 cost sharing is specifically in the master plan document for this year, yes.
Darn it, I hate to be wrong. Oh, man.
I'm sorry. Right now, we're not cost sharing, so that's what's in the plan document. I'm sorry, I just needed to clarify.
Yes, Laura Rich, for the record, it was updated this plan year to ensure that was something that was covered in the plan document, yes.
Member Aiello, waving frantically.
Betsy Aiello, for the record. With that statement then, Executive Officer Rich, has there been a problem if our HMO has not been following it, if it's in the master plan document? Are they required to follow the master plan? That's something that brings up to me then.
So Laura Rich, for the record, the master plan document applies to our self-funded plans. And so each self-funded plan has its own master plan document. The fully insured HMO product does not fall under the requirements of the master plan document. They have their own master plan document.
That's good to hear. Thank you.
But that does change the conversation. Sorry, Michelle Kelly for the record. That does change the conversation for the board because there is a notice requirement now, right? It's in the plan document. We're planning to take it away mid-plan year.
I would have to check with legal. We didn't have to do that when we implemented, so I would have to check with legal on that one.
When we implemented, it was an enhancement to the benefits, so no one was going to complain. When we take it away, it's something that's published. Can we? My question would be, can we even do it mid-plan year, given there's a published document that states it?
This is Laura Freed. I'm going to call on Deputy Attorney General Briggs to opine.
All right, Michelle, Chief Deputy Attorney General. So if the plan document, I'm not quite sure what the plan document says based on what's been discussed. But the plan document says right now that it is cost sharing. Is that what you had said,
No.
Ms. Rich?
No, the master plan document apparently codified the change the board made some months ago to cover COVID treatment at 100% rather than the typical cost sharing that is normal for, any infectious disease. So the question is, can the board decide if it chooses to reinstate cost sharing, is January 1st, 2022 too soon because there is a 30-day notice to change the provisions of the plan? So would we have to push it out?
Yes, you would have to follow all procedures to change the plan if the plan currently says that it is fully covered.
So, and I think we have, I believe, Michelle Walker from Health Plan of Nevada. Michelle, if you're available, or maybe Mark, would you, either of you, mind speaking to how Health Plan of Nevada reinstated that and what the process was? Wendy, do you know if Michelle or anyone from HPN is on? They should be.
Broadcast Services, this is Laura Freed. Do you have any folks on the Zoom from Health Plan of Nevada or Southern HMO?
Hi, Chair. This is Cindy with Broadcast. 1 second. Are you referring to Ms. Michelle Briggs?
No. She's the chief DAG. Laura Rich, can you help me with the names?
It would be Michelle Walker or Mark. Oh, there. Okay.
But we do not have a Michelle Walker on the Zoom.
Mark Thorlton, HPN for the record. Just got a text. I was waiting to confirm. We did not change the fully insured certificate of coverage when we made that provision change. We knew it was somewhat of a temporary adjustment to that plan to waive those flat co-payments for inpatient, outpatient treatments of COVID. So the plan document, or the, in the case of a fully insured plan, the certificate of coverage was not amended. And then again, when we reverted back to applying those co-payments, it was also not adjusted. So it was simply an administrative adjustment that was made to make that change and that accommodation.
Thank you very much for that. Member Kelly, do you have a follow-up for HPN staff? Okay. All right. Did you have a follow-up for Ms. Rich?
I guess I have a question about, are we, given that the change in the COVID coverage was in the master plan document, would it be safe to assume that some of our more savvy covered members potentially switched from an HMO to the PPO because they knew they would be covered at 100%? If I would argue that potentially we have even one member out there who did that, and if we are going to change that coverage, even with notice, we need to open enrolment again to allow them to select a plan that better suits their needs, because that is the purpose of open enrolment, is to give people an opportunity. So I think, anyway, I'm pro cost sharing. I just am concerned about the procedure, because it's my understanding we're obligated to operate our plan in line with our plan document. So.
This is Laura Freed. I guess that would mean that member would have to be sitting there in May and thinking, well, who covers COVID, and how many, and am I going to get COVID? And I don't know that anybody sits around thinking, I'm going to make a decision based on whether I get a COVID case or not. So I'm not sure I agree with that. Mr. Barnes.
Yes, for Ms. Rich, if it's determined that we need additional vaccines over and above what we have now with the new variants emerging and that sort of thing, will PEB need to implement additional surcharges if we do need additional vaccines?
Laura Rich, for the record, at this time, that's not being considered. It's something that the board can definitely consider in the future. It's something that the governor's office can work with PEB on, but at this point, that's not something that we are considering.
Thank you.
Mr. Verducci.
Yes, Tom Verducci for the record. Are there any other states, we may have discussed this, that are using a COVID surcharge, or would we be the only one out there?
Laura Rich, for the record, we obviously have not checked with every single state. We did reach out to a resource that we have that does distribute emails to different public entities, and we've received a lot of responses from public sector health plans that were very, very interested, but had not implemented yet. They were looking at it, but they had not implemented yet. There was one public sector health plan, a small one in, small-ish one in Dallas that did implement a surcharge, and they actually went above and beyond and implemented some incentives as well, provided, 2 extra days off for those who had gotten vaccinated, and so they took some extra steps on top of that. So we do know of public sector plans that have done it, but this has been more common in the private sector among large employers. So like Delta and Boeing and several large employers like that.
Okay, so Tom Verducci for the record. So we would be the only state that would actually be implementing COVID surcharges.
Laura Rich for the record, that I know of, we would be the first state, yes.
Okay, and from a risk management perspective, liability and unintended consequences, especially that $175 family charge, and the state employees have been hit very hard with no raises over a number of years. And I think of the soul out in the Lovelock working for the Department of Corrections is paying $800 a month in a trailer with 3 kids. I have a hard time with this one. I really do, and I just wanted to pass on my personal comments. No question there. Just a few comments from compassion of working with state employees in the 80s, 90s, the 2000s, the 2010s, and now the 2020s, and meeting a lot of them personally. And I just have a hard time with this hard dollar cost after the cuts that they've incurred.
Thank you, Mr. Verducci. All right, I'm not seeing a lot more questions, raised hands. Looks like we're all discussed out, so feels like it's decision time, my friends. All right, knowing what we know that the plan has to provide notice, I think I'm going to do this. I'm going to do this in chunks. And so I'd like to tackle recommendation 1 first, reinstate cost sharing for COVID-related treatment and hospitalization, and apply existing plan rules, that is the normal master plan document for the CDHP, related to COVID-related treatment and hospitalization claims effective. Now, we at least need to push this out to February 1st, or we could do March 1st, or we could do FY23. What is the sense of the board on that point? Ms. Biddleston.
Leslie Biddleston for the record. I support pushing it out to March 1st of 2022, which would give staff 60 days to notify.
Fair enough. Would you consider that a motion?
Leslie Biddleston for the record. I move.
No, that's great.
I move that we reinstate cost sharing of COVID-related treatment and hospitalization, and all of that effective March 1st, 2022.
Okay. Is there a second?
Linda Fox for the record. I will second that motion.
Okay. Thank you. All right. It's been moved and seconded to reinstate cost sharing for COVID-related treatment and hospitalization for the CDHP effective March 1st of 2022. All in favor say aye.
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 Aye. Any opposed say nay. Oh, I'm sorry. Let me give you a second. Thank you. Any opposed say nay. Hearing none, the motion passes. Thank you. All right. Recommendations 2, 3, and 4. Let's take number 2. PEB staff recommends allowing surveillance testing coverage only through PEB-sponsored vendors. That is only covered if you go through the vendor that is ultimately worked out between PEB staff and our medical vendors or our pharmacy benefit manager. Board members, do you have a sense of your direction on that?
I'll make that motion.
All right, thank you, Member Kelly. Is there a second to that motion?
Linda Fox, for the record, I'll second that motion.
Okay, thank you. All right, so it's been moved and seconded to allow surveillance testing coverage only through PEB-sponsored vendors. Board members, all in favor, signify by saying aye.
Aye.
Aye. Any opposed, say nay. All right, thank you. Motion carries. All right. Here it is, friends. Implement, number 3, implement a COVID surcharge effective July 1st of 2022, so effective in plan year 23, for all unvaccinated primary members of PEB of $55 a month per employee. Board members, how do you feel?
Well, Tom Verducci, for the record, I'll be voting no on this one.
Okay, thank you.
Linda Fox, for the record, I will make that motion that we implement the $55 surcharge for unvaccinated employees.
Okay, thank you. Is there a second to the motion?
Leslie Biddleston will second.
Okay, thank you. All in favor signify by saying aye.
Aye.
Aye. Aye. Any opposed, say nay.
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 Okay, the record will reflect Mr. Barnes and Mr. Verducci as nays. Motion carries. Last but not least, the recommendation is to implement a $175 a month COVID surcharge effective, again, July 1st, 2022, so plan year 23, for unvaccinated spouses, domestic partners, and dependents 18 or older. And to this, given the uncertainty of testing costs, if someone is going to move approval of this, I might suggest allowing PEB staff to, as testing costs are revealed to us and to PEB staff, giving the PEB staff the flexibility to lower that surcharge, not increase it, but lower it. So in essence, making $175 a month a cap, and anything beyond that would have to come back to the board. But that's my own personal feeling. So board members, sense of the board?
Michelle Kelly, so moved.
All right. Thank you. Is there a second?
Leslie Biddleston will second.
April Karn, I'll second.
Okay. Oh, okay. I'll take Ms. Karn. She hasn't got a second yet. All right. All right, board members, you've heard the motion. Implement a $175 a month COVID surcharge effective July 1st, 2022 for unvaccinated spouses, domestic partners, and dependents 18 or older, with approval to PEB staff to lower that surcharge if testing costs prove to be lower for the plan. All those in favor say aye.
Aye.
Aye. Any opposed say nay.
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 All right. The record will reflect Mr. Verducci and Mr. Barnes as nays. Motion carries. Thank you, everybody. With that, we will move to agenda item 7. Oh, I'm sorry. Yes, of course we can take a break. Let's take a. It's 10. Sorry, guys. You always have to remind me whether we're virtual or we're not virtual. But you guys can always go to the bathroom no matter what, since we're in person. But yes, let's come back at 10:55. It's 10:47 now. board members? If you could return to your seats, we'll get the meeting back rolling. All right, ladies and gentlemen, we'll call this meeting of the PEB Board back to order. All right, thanks everybody. We'll move on to agenda item number 7, discussion and possible action on potential program design changes for plan year 2023.
All right. For the record, Laura Rich. Just to give a little background on this, at the September 30th board meeting, Aon had presented information regarding plan trend and the impact of COVID and recommendations related to PEB's differential cash levels. Aon's original recommendation expected, after all the expected trend and required expenditures such as the Medicare HRA funding and premium buy-downs, the recommendation by Aon was to use $12 million in differential cash. So the board later approved that the $12 million be used to develop plan design that could be funded over 3 years with a primary focus of restoring deductibles and out-of-pocket maximums. So since the last board meeting, many changes have taken place that have led PEB and Aon to go back to the drawing board and make new recommendations. Fortunately, they are much more improved recommendations. Aon has been able to run much more recent utilization and apply a variety of very significant savings that are projected to come to the program as a result of new contracts that are in the process of being awarded. Some of them will be awarded today. So after factoring in additional CRF dollars, and let me go back since we have not discussed, or we took some items out of order, but we are getting additional CRF money from CARES Act funding from on the IFC agenda in December, in addition to the $5 million that we received last IFC as well. So with those CRF dollars, the recommendation has increased from $12 million to approximately $26 million. Because some of the contracts, such as the PBM, they have not been finalized yet, approximate savings were used, so we're not necessarily completely on target because we don't know about some of these. We know that there's going to be savings, we just don't know how much because they haven't been awarded yet. So some of these approximate savings were used in this figure, and so depending on the outcome of the final negotiated contracts, this may impact the actual savings and what that differential cash would have been, that recommendation would have been. But we feel like we're pretty close based on the projected savings and what we think the outcome is going to be on some of these future RFPs. So on page 2, you can see that there's a chart there that shows trend, and I think it's a very good visual example of trend. And for those of you who, I actually have a black and white copy as well, but if you see, I think it's a green line, right? On page 2, so this chart right here. So on page 2, I believe it's a green line, and that is the total trend, so that is medical and RX combined. So you can see that the black line there in the middle, the fairly flat line, that's our budgeted. That's what we have budgeted for overall. That's what the plan has received in our legislatively approved budget. And the costs there are, that green line is what is actually happening in the plan, right? So you can see that in 2020, you can see those suppressions. You can see that it dipped down, and this is where a lot of our excess reserves or differential cash has come from. because people were not going to see their providers, they were not seeing they were not going to the dentist, they were not seeking care in general because of the shutdown. So we had that suppression in 2020. And then we've been talking about this spike in claims, this comeback, right? So all those folks that didn't go to the doctor are now seeking services. And so you can see that there's a spike in claims, and this is happening. So the differential here is between the black line and the green line. This is what we're missing, and this is the reason why we cannot use up all of the excess. We have to have that bucket of money to really take into consideration the difference between the black line and the green line. So I thought that chart there just really did a good example of illustrating the impact of COVID, because it highlights the claim suppression and the beginning of that anticipated spike. We don't know how long that spike is going to last, and what that is going to look like moving forward. So this is why the entire amount of our excess reserves or differential cash is not being recommended to use. So with the assistance of Aon, and we do have the Aon team here in front of us, staff and Aon have come up with some plan design options that used a couple different approaches. So in option 1, the plan design basically takes a very conservative approach. So we're looking at, our recommendation is let's use $26 million in excess cash, in differential cash. And this plan design is, this option 1 is using $21.7 million in differential cash. So if you look at the plan design, the focus here is on the reduction of deductibles and out-of-pocket maxes, just as the board had decided on at the last board meeting. So there were a few reductions there in deductibles, out-of-pocket maxes, and then on the EPO and HMO, there were some changes there in the copays as well. So, and if I'm going to pull up my colored copy just really quick, because that way I can see. Yeah. There we go. Okay. All right, and so in option 2, the plan design takes the moderate approach, and that's where we are using approximately $26 million, which is what staff feels comfortable recommending in terms of how much of that differential cash we feel is a safe amount to use. And in this option, you can see that those deductibles and out-of-pocket maxes are reduced a little bit more. You're looking at different copays on your EPO and HMO, and the cost sharing as well for RX. So that uses $26 million. And then option 3, the plan design here takes a more liberal approach. So here we're using more than what staff is recommending that we feel comfortable with. We're using $34 million instead of that $26 million in differential cash. And what this plan does is it restores plan design back to pre-pandemic levels as close as possible, because if you recall, the low deductible plan was introduced in plan year 22, and so the low deductible plan did not exist pre-pandemic, and because you've got to space out the actuarial values between the 3 plans, you don't want 3 plans that are exactly the same, we had to kind of tweak the plan design a little bit to closely mirror that pre-pandemic benefit level by adjusting for the copay plan design as well. And so in this plan design here, we do have again, the restoration of the deductible back down to $1,500 and $3,000 for the CDHP, the copay at 0 for the low deductible plan, the EPO is at 0 as well, and we've adjusted those out-of-pocket maximums as well. So there are some options here. We also, after speaking to some board members, we came back, and what we did was kind of tweak some of these plan designs, and so that is the amendment that was distributed yesterday. And so you can see that there's some options there where instead of an option 2, we're keeping the copay pretty low on the deductible, but we're making that HMO and EPO $0. We've also looked at some other options, right? And so those alternatives are alternatives to option 2 and 3 for those plan designs. So keep in mind that a lot of this, obviously there's a lot of contracts that are out there right now. There's a lot of volatility within our plan. We do feel as staff, with the recommendation again of the Aon team, that $26 million, we feel pretty comfortable with that amount. Going over that is, we're not quite ready to recommend going over that amount to restore plan design, because we don't know what it's going to look like. We don't know what costs are going to look like, what COVID costs are going to look like, what the spike is, when that is going to end, right? And, what medical trend is going to look like moving forward. So those are all options to consider. The other thing, too, is that the board also I'll have to remind the board that regardless of the recommendation or what is the action that is taken today, it will require the approval of the interim finance committee, because this is using differential cash to fund benefit plan restoration, and so this will need to be brought back to IFC for final approval by the legislature. So with that, I will take questions. I think that we also have the Aon team here who's ready to answer questions as well. So I'll leave it at that.
Thank you. All right, so this is Laura Freed for the record, by the way. So at the last board meeting, board members, we voted to spend about $4 million in differential cash in FY23, 24, and 25 to enrich plan design. This report is giving us options to increase that. For option 2, it would be about $8.6 million per year, and option 3 would be about $11 million per year over the 3 upcoming fiscal years. Questions on the details of what would change in these options? Mr. Barnes, yeah, go ahead.
I had a question. Now that the COVID testing policy and the surcharge have passed, how does that change the calculation of available excess funds?
Laura Rich, for the record, it should not change the calculation at this point, because we are using the surcharge to cover the cost of testing. And so had we not approved the surcharge, we might not even be having this discussion today, because we would have to allocate other funding for those testing costs. And so it shouldn't affect it. Now, that being said, we don't know what the future looks like, and so there's definitely room to potentially next year to reassess, right? So we're making a 3-year decision here because we don't want to apply all of the funding to 1 year and this fiscal cliff that you keep hearing about. So we're spreading it out between 3 years. That doesn't mean that next year, in November, this time next year, that when we're discussing plan design again, that this can't be reassessed based on new information.
So Aon didn't include this in these costs in their estimates then?
The surcharges were not included in that, but Colleen, I don't know if you want to speak to that.
Sure. Correct. We did not, Colleen Huber for the record with Aon Consulting. Correct. We did not include additional surveillance testing or surcharges into our excess capital reserve level.
Okay. Thank you.
Member Aiello?
Betsy Aiello for the record. And you had mentioned then that option 3 was about 11 million of differential cash in each of 3 years. But some of that would have been the CFR dollars and the savings also, correct? So it isn't quite that much in differential cash?
The coronavirus relief that we're going to get coming up at IFC, I expect, is being used in this plan year, 22. And after that, I mean, you can't get CRF after December 30th, I believe it is. So this is, I mean, we don't expect to get any other federal money for COVID claims in 23 and beyond. But I'll let Laura speak to that in more detail.
Laura Rich for the record. So, right, so the CRF funds that we're receiving are specifically to be reimbursed for COVID claims that have already been incurred, right? And so those claims are through the end of December 31st, so the end of the year, December 31st. And so that CRF money that we are receiving, although it's being factored into the overall picture here, it's because the plan is receiving the money and it is being allocated directly towards those claims. But as it, downstream effects, right, it's money that the plan didn't spend on those claims because we've been reimbursed through CRF. And so it adds to the potential differential cash that we've got to play with at the end of the year.
So this is Betsy again. So my question is, because I'm trying to figure out, the trend is not accounted for between 5 and 15%. So at least that's my understanding. And then we're taking differential money and spending it either in 1, 2, or 3. How much money do we have that is differential, or we're planning to do between the 5 and 15 or 5 and 10, if it's that? Because I'm thinking we have some money we're planning there for the added claims, or am I off thinking here?
Okay. Colleen Huber for the record with Aon. So you are correct. So we have in our, if you go back to the trend, it is peaking at that 12% right now, but we don't expect that to continue. The 12% is really coming off of where the year prior, the claims were suppressed so dramatically because of COVID. So when we were expecting over time and through the end of plan year 22 for trend levels to return back to normal or historical levels. So that's where we went back after the last board meeting, analyzed all of your claims, used as much information as we had at that point, looked at historical trend levels and what the current trend levels are today, realizing that the prior year the claims were suppressed. We don't expect to see 12% through the end of July of 22. So as it returns back to normal levels, what do we project as of June 30th, 2022? What will the excess surplus be at that point? And then to Laura's point, then we factored in the any available, the funding that was received during this plan year or this calendar year, as well as what we knew at that point as far as contract savings as a result of the procurements going on. Does that answer your question?
Yes, but then, so you factored all those in, and so then is it projected that if you say we're going to spend 26 or 28 or 33, which one zeroes out the differential cash after 3 years?
The 26. So as of June 30th, 2022, we're expecting the excess, Colleen Huber for the record, at the end of June 30th, 2022, we're expecting your excess surplus to be $26 million. If we were to spend that surplus over a 3-year period, that would be option 2.
This is Laura Freed. I have a question, probably for Colleen Huber. There's a footnote on their revised plan design summary that we got yesterday, and it says, based on incurred claims, normalized for claim suppression due to COVID-19, trended to plan year 2023 based on a 5% medical and 8% prescription trend. So this was projected based on 5 and 8 for the next 3 fiscal years?
Colleen Huber, for the record, correct.
Okay, got it. Thank you. Mr. Verducci?
Yes, Tom Verducci for the record. So what I understand, Laura Rich had mentioned that the anything that's approved here has to go before the IFC and the GFO. Is that right? So let's say we went back to our July motion to restore the benefits to the pre-pandemic levels, and say we did suggest an option 3, but say it was cost prohibitive from the IFC and GFO. Couldn't there be some hybrid model? I mean, I'm just wondering, why would we just limit the option 2 and not try to enhance the benefits to the best of our ability within our budget constraints, and then let it go before the IFC and GFO and see what's affordable?
Laura Rich for the record. It's certainly something that the board, an action item that the board can take, perhaps the board can vote on, let's say, option 3. Should it not get approved, then we revert to option 2. But again, this all would have to go through IFC, and it's a good question. I don't know, because we don't have a long runway, and we do need to be able to price out the plans in March. And so Aon needs to understand what that plan design looks like by February in order to come to the March board meeting and be prepared for rate setting. And so we don't have a lot of room and timing for that, especially given that we're bound by the IFC schedule. Yeah. So it's really, it's risky.
Tom Verducci for the record. So I think any decision where we go on this should allow some technical adjustments in terms of some of these variations that we've made. Like, for example, I don't understand how some of our co-pays had changed here. I mean, where do these figures come from? Was this from Aon as far as some of these technical amendments on the plan design?
Correct, and if Aon wants to address that.
This is Colleen Huber with Aon for the record. Correct. So within the grid itself, I'm not sure if the question is on the grid itself, but you have your current level, your current plan designs, with the column to the right of it, the pre-pandemic plan designs, and then the proposed is the third column, and that you can see the impact of the how much of that would cost over the 3-year plan design. And so we modeled it out for the CDHP plan, the copay plan, and the EPO HMO plan in the far right-hand side. So all of the cells that are colored green, I don't know if you have a black and white, but the items that are green are the changes where we're trying to enhance the plan design and make the actuarial value where the plan pays a greater share of the cost compared to the member. All of those changes are outlined in the green font.
Okay, thank you. Yes, because I do see variations here in deductibles, and I just don't ever recall having a discussion on the plan design and coming up with these figures. So I was just trying to ascertain where the figures came from. So I do see it's a process of Aon coming up with the final numbers here.
Right, and this is Colleen Huber, again, for the record. Our goal here was trying to target certain dollar amounts while we were also trying to balance the impact of the actuarial value, so how we measure what the plan pays as opposed to what the member is. We wanted there to be enough spread such that the member would understand the different benefit offerings and then make the decision that is best for them in the most transparent way possible.
Thank you.
Sure.
I'll go to Member Kelly and then Member Aiello.
Michelle Kelly for the record. I just have a question about the self-funded plans, or primarily the CDHP, what percentage of participants hit their maximum out of pocket on a rolling 3-year average? And I know that this year skews it, but I'm still kind of interested in that 3-year picture.
Colleen Huber, 1 second, we have that, and we actually looked it up based on last board meeting, so.
Can I ask a follow-up while you were looking for that then? Because it probably needs looking up as well. I'm just wondering, I'm also curious in the cost of each $100 of HSA employer contribution on the CDHP.
Yeah, this is Tim Zettinger for the record. So we have the last 2 years for PY20 and PY21 for the CDHP. About 6% of employees or contracts have reached their out-of-pocket maximum. For the EPO, we have 1.2% for PY20, and for PY21, we have 0.5%. And then for the HSA, so for every $50 of seed that we give to the employees, this costs about $3 million. So for $100 of seeding, it would be $6 million, and that's over the course of 3 years as well.
I'm sorry, I just want to clarify that. So it's $50 million for $50 per year for 3 years?
$1 million for a $50 seed per year.
So this is Betsy Aiello, for the record. And this is probably a very elementary question, but as we heard, you'll come back in February or March and do the rate setting. And the rate setting is based on the plans we've chosen. And so for sure, if we choose option 2 or option 3, everything else remaining the same, the premiums for option 3 will be higher than the premiums for option 2. So one of the things we're looking at here is we've heard a lot of testimony that people want the higher benefits, but I'm not sure that people want the higher premiums if they realize that that's what it's doing. But February is going to be February, and so option 1 would have the very lowest premiums, option 2 middle, and option 3 higher for all categories would be my guess.
Mr. Barnes.
Yes, Jim Barnes for the record. I wonder, how confident is Aon in these projections? I mean, what's the range of likely outcomes? Are you confident that these are on point? Because I know for a dozen years running that it's always been over conservative, and I wonder if that's done on purpose, or do you feel confident that these are hard figures?
So this is Colleen Huber for the record from Aon. So these are the best information we have at this point. So we are using your most up-to-date claims experience with the trend levels of 5% for medical, 8% for pharmacy, and 3% for dental. We also factored in to account any contract savings that were a result of your procurement at that time, as well as we did take into account the potential savings that is out there today as a result of potential procurements once you award that business. Now, if you don't award that business, obviously that would directly impact our calculations. The biggest unknown would be on the trend side. So, and again, with the COVID factors and anything that could potentially impact your trends, we went back to your historical levels, realizing that is most likely the best indicator of your trend that we can see at this point. Now, taking into account what we've seen in the last 2 years as a result of COVID with the very large claim suppression, and then followed by the claims being returned back into the system, we're just trying to use the best information that we can as we get. So we realize that when we come back in the spring, we will again refresh all of our numbers, taking into account the most up-to-date information that we have, whether it's the inflation levels, whether it's current trends, whether it's national trends, Nevada's trends specifically. We try to factor those all into consideration as much as we can, and then continually refresh our projections such that you all, as the board members, have the information that you need to make those decisions.
Okay, thank you.
Sure. This is Laura Freed. I think it's worth pointing out that legislatively approved trend for 22 and 23, medical is 3.52% and prescription is 4%. So for Aon using 5 and 8 as sort of post-COVID normalized is still higher than what PEB has in its budget for trend. And that's one of the reasons that, I feel a little bit less comfortable with option 3. This is tough for me because I would like to restore benefits and, make things sort of what they used to be for participants as much as anybody else. But to Member Aiello's point that, $26 million is the cash we have. And so so the differential between 26 and 33 has got to come from somewhere. And it's not coming from subsidy dollars because that's set in law. So it's coming from premiums. And that's the choice. So, and we've got a trend in the ledge-approved budget that is less than what our actuaries think it is. It really is, or should be, to the best of their knowledge. All right, I'm sorry, Ms. Biddleston, you had a question?
Yes, Leslie Biddleston for the record. On the addendum, it says that this assumes an 80% vaccination rate. So when we, the members, start providing our vaccination information, when we start doing the COVID surcharge, my question is, will these plans change if we find out that there's a actual 60% or actual 90%? Will the numbers change when we get the actual vaccination rate?
This is Colleen Huber for the record. The vaccination rate will not change the plan designs at this point, so there will be no result of that. Thank you.
Mr. Verducci, go ahead.
Oh, thank you. Tom Verducci for the record. I'm trying to figure out what we have in differential cash, excess cash. We normally have a budget and there's utilization reports in this binder, and I'm kind of wondering why we have such thin material here. It's usually a real thick packet that shows up, and we have a thin packet today without utilization and budget reports, and just wondering where did it go?
Mr. Verducci, this is Laura Freed. I think I'll take the blame for this one. I made a concerted effort thinking that items 6 and 7 would take a long time and there would be voluminous public comment, and I didn't want to make you guys commit 9 hours to this meeting. I removed from the agenda a lot of the usual budget report and utilization report stuff that you're correct we do see. I wouldn't normally do that, but I made that decision based on time constraints because I don't want you guys to starve to death and stay here all day.
Tom Verducci, I actually prefer the additional information, just as an FYI.
Noted. Okay.
Normally we have the performance guarantees, and my question that I couldn't find here is how much excess reserve do we currently have on hand? I think I was reading 40 million. And I don't know if that's overstated or understated, but usually that comes out of the budget report.
I'm going to put our CFO, who's on Zoom, on the record here. Carrie, do you mind giving the exact amount?
Hello, this is Carrie Eaton for the record. I believe it is projected at this moment. Sorry, it's not pulling up. I believe it was at around 30 million, but I will try and get it pulled up.
So Laura Rich for the record, at the last board meeting, we were looking at close to 40-ish, but we've made, obviously, there's some buy-down subsidies and Medicare HRA and things like that we are required to use that differential cash for. And so that has, that would bring down those numbers. But what I do want to say is the projections, again, overall, we have to keep in mind that the projected savings from all of these contracts are taken into account here, and that is not part of the budget report. And so what we're looking at is projected savings, and I can't go line item by line item, and I have to aggregate it all because of the confidential nature of the solicitation process, but there is a very significant amount of savings in these contracts that have contributed to the higher amount. And so, Mr. Verducci, it's not necessarily just what you would see on the budget report. It's additional items that staff and Aon have taken into consideration because of the projected savings that the plan will likely experience next year as these contracts are put into place.
And this is Colleen Huber, just for the record. Aon is working very closely with Laura and her staff, just such that with every type of negotiation or contract change or procurement award, we are always reevaluating and incorporating that into our projections, just so to ensure that we are using the most up-to-date information possible. So we try to work closely with Laura and her staff on that.
And this is Carrie Eaton for the record again. I did pull up that projection, and currently the projection is at 13.5 million. But it does change throughout the year.
And Laura Rich, for the record, this is also part of the discussion as to why we only discuss differential cash one time a year. It's a snapshot in time. It depends. It goes up and down throughout the year. And so it is very difficult to take a point in time. Just like Carrie said a month ago, it was probably a lot different than it is today, right? And so it's just a snapshot in time. That is why we have made a decision to discuss that one time of year, and that is after the budget is closed and we've closed the books for the year. So that's at the September board meeting. So what we're using here is the September board meeting information and what we've done since then in terms of projections and cost savings to the plan.
Member Kelly?
Michelle Kelly for the record. So I'm just looking at the different options, which kind of expanded to 6, right, from 3 to 6, and just with slight tweaks. So, Executive Officer Rich, which is the staff's recommendation at the moment?
So the staff recommendation is really any of the options that hover around that $26 million, right? And so that is what staff feels comfortable with. So in terms of, option 2, we're looking at either option 2 that was originally in the report, or the slight tweaks in option 2 that you see in the addendum, right? And so really either one of those works. The option 2 in the addendum is more closely to similar to the plan that's in place today, where the EPO and HMO have lower or no copays to the copay plan, right? And so the addendum it kind of tweaks it a little bit to more closely relate to what we've got today. But really, staff is comfortable with anything that the board would choose that uses that $26 million option.
And just Michelle Kelly for the record. So just a follow-up on the CDHP. So none of the kind of option for that is the same across both different designs, I guess, one and one on the revised. Can you talk about why the choices you made here? I know the board had directed in September kind of bringing those deductible and the OOPs down. And in this option you've done that, but you've left the HSA stable between now and kind of 600 and 600. Did you explore kind of looking at maybe keeping the OOP a bit higher and offering members of that plan a little more in HSA money? Did that end up being cost prohibitive? Was there is there rhyme or reason to this choice, I guess?
So I think that Tim or either Colleen can address this. I know that they've looked into this and have this information available as well.
Yeah, so this is Tim Zettinger for the record. We looked at what we could provide to each employee, an HSA seed, to replace those out-of-pocket maximums on each of those options. So for current plan designs, we have a $5,000 out-of-pocket maximum. And for option 1, we dropped that to $4,400 for employee only. Now, we could provide each employee in the CDHP $80 of HSA seed, and that would have an equal cost for the CDHP over 3 years. Similar to option 2, we could provide $160 in HSA seeding and replace that $4,000 out-of-pocket maximum. And then in option 3, we could provide $180 in seeding to replace the $3,900 out-of-pocket maximum. So if all of those options went back to the $5,000, $10,000, that's what we could provide for the same cost over the 3 years in HSA seeds.
Mr. Verducci.
So, Tom Verducci for the record. So, what I'm reading here is option 3 would be $33 million for the next 2 plan years, and option 2 would be $26 million. So we have a difference of about $7 million, and we just approved COVID surcharge that brings more money in. And if we don't end up with the full $33 million, there could be some give and take as we get into the next meeting. I'm kind of supportive of option 3. I know $26 million is more in line with option 2, but I like option 3.
Is that a motion, Mr. Verducci? Or is that just a statement?
Well, if we're down to motion time, so move.
Well, I don't know. Are we down to motion time? I mean, I always love when the questioning peters out, and I'm sort of trying to get a sense of, all right, are we ready to make a decision?
Okay, so Tom Verducci, So, Tom Verducci, I'd like to make a motion that we approve option 3.
Okay. Board members, is there a second on that motion?
I'll second.
All right. All right, so the option before the board is to use $33 million. In other words, so option 3 of the revised plan design that we got yesterday, not the original option 3 that we got in the original meeting packet, for a total of $33 million in differential cash. Oh, I'm sorry. Yes, is there a question on the motion?
This is Betsy Aiello for the record, and I just want to ask another question. We really aren't going to run out of money because this option will be priced higher in premiums, correct? Or we could run out of money?
I'll take a. I would love to kick it to Aon, but I know from budget experience. But I'll stop talking. I'll run my mouth. I'm fine. Yes, I think is a short answer because we've only got one more fiscal year of this current biennium, and we have cash in the bank, if you will, more than what it would cost for 1 year of enhancement at option 3, but then we don't know what happens in budget years 24 and 25, and if we end up with less than the 3-year total of $33 million, right, that would be an increase in subsidies during budget building or an increase in premiums during plan design and rate setting. So you're right in that sense. Aon, would you like to add anything to that?
This is Kelly, and I agree with everything that Laura Rich just said. Also keep to account, I mean, and I'm not sure, these would be the plan design changes for the next upcoming plan year. I would imagine, and you also, since it's a 3-year look, you may be able to also readjust them if needed as well. That might be another option too.
Michelle Kelly here.
I'm going to throw it to Ms.
sorry.
Biddleston first, then I'll go to Michelle Kelly. Okay.
Leslie Biddleston for the record. I'm not supportive of premium increases, and I think option 3 would increase premiums for all members. And I'm also very concerned about sustainability. We talk a lot about sustainability, and listening to executive member Rich, she provided those different options and then what the board was comfortable with. So I would rather go with a more conservative option rather than give members benefits for a year or two and then run out of money and have to come back and say, sorry, no more money, we have to change again. So I'm concerned about premiums, and I'm concerned about sustainability, and I won't be supporting option 3.
Okay, Member Kelly?
Michelle Kelly for the record. So, I think one of the struggles for everybody involved in this process is that in the past, Aon has done its job very well, and its projections have been conservative. Even the aggressive projections have been somewhat conservative, and we have ended up with excess reserves that have been swept by the state. And so I think that given that the board made the very prudent decision in September to kind of try and spread these giving back the money across 3 years for good reason, so that we didn't have to increase premiums, and we also, could keep plan design somewhat stable. I acknowledge that. I think it's a really prudent decision, but I also think that employees right now are extremely challenged, and that's why I'm supportive of this motion, that we have the option, if claims projection gets worse over the next 12 months, it's going to start to tell a story, right? People are getting services again. I think the board has the option every year to tweak plan design, and I think that I'm supportive of the more aggressive conservative option this time, because I do think we have options available to us in year 2 and year 3 if it gets out of hand, as in the trends get out of hand or we do start to spend our money. And I think we can do that prudently, and I think employees will understand. But what I heard during public comment is that employees need the relief now, and so that's kind of where I'm coming from. Thank you.
Okay. So there is a motion on the floor. It's been moved and seconded to approve option 3 to use up $33 million in differential cash over the next 3 plan years. All in favor signify by saying aye.
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 So I have Mr. Barnes, Mr. Verducci, and Ms. Kelly. Do I have any? Oh, and, okay, thank you, Ms. McClendon. Okay, so that's nays. Say nay.
Nay.
Nay. Nay.
So I have Ms. Biddleston, myself, Ms. Fox, Ms. Curran, and Ms. Aiello. Okay, motion fails. Do I have an alternate motion?
Linda Fox for the record. I will make an alternate motion, and my motion would be option 2 in the original packet we were given.
Option 2 of the original packet. Okay. you have a second for that?
Leslie Biddleston, second.
Okay. All right. So it's been moved and seconded to approve option 2, using approximately $26 million in differential cash from the original packet's plan design, not the updated one from yesterday. All those in favor signify by saying aye.
Aye.
Aye. Any opposed, nay?
Nay.
Nay.
Okay, motion carries. All right. Okay, since we took 6 and 7 out of order, now we're going back to agenda item 4, the consent agenda. Board members, you've seen the minutes and the PEBS ARP rescue plan funds request. Do you have any questions on either of these consent items? Hearing none, I'll accept a motion to approve.
Leslie Biddleston, so moved.
Okay, do I have a second?
April Karn, for the record, I'll second.
Thank you. Okay, all those in favor signify by saying aye.
Aye.
Aye. Any opposed, say nay. Okay, motion carries. Executive Officer Report, agenda item 5.
All right, Laura Rich for the record. A lot of the stuff we've already covered, actually. The federal funding update. As the board knows, in October, the Interim Finance Committee approved PEB's $5 million work program for the use of CRF funds. So we will be receiving $5 million for reimbursement of COVID-related claims. But in November, PEB was informed by the Governor's Finance Office that an additional $5 million would be made available to PEB for additional CRF money that is set to expire on 12/31/21. The problem is that these claims have to be reimbursed, and they have to occur and be reimbursed by December 31st. And so we did not project that we were going to have an additional $5 million in COVID-related claims by that point. And so we've reduced that amount to $3.6 million in CRF funding. So that is on the December IFC agenda for consideration. And then, you've heard also from Director Young, who, even though we have received $14.9 million in CRF funds to date, not inclusive of that $3.6 million that we are set to receive at the next IFC, it does not appear that PEB will be receiving additional funding through the American Rescue Plan appropriations. There's unfortunately too many competing priorities, and so that is not something that the plan is going to receive, as you heard Director Young speak to earlier. The enrollment and eligibility system update. We just wanted to talk about some implementation issues. So around this time last year, LSI was awarded the contract for PEB's Enrollment and Eligibility System, RFP. LSI is also contracted through the Office of Project Management to oversee the Smart 21 statewide ERP implementation. This replaces the state's legacy IT systems, including finance, payroll, and HR management. Although LSI won the contract for the enrollment and eligibility system, the work with PEB is mainly being performed by their subcontractor Benefitfocus. So with only weeks until PEB is due to go live with this new system, it's become apparent that there's a significant chance of some critical functionality that may not be ready by January 1. A major component of the implementation has involved assumptions involving PEB's ability to integrate with the new Smart 21 technology rather than the current antiquated IT systems that the state has in place today. But delays in the Smart 21 project have added additional unplanned for and out-of-scope integrations that have hindered PEB's progress on our enrollment and eligibility system implementation. So in addition, the challenges experienced on the Smart 21 implementation have taxed critical resources, which are also vital to PEB, DHRM, and the DHRM is the Division of Human Resource Management, and the Office of Project Management. Throughout the implementation, there's been many assumptions that have been made, some lack of communication, some late changes, and components that were not thoroughly discussed, and that has contributed to concerns about a successful go-live at the end of the year. In several cases, the issues causing concern were not brought to our attention until very recently, and when I say our attention, it would be PEB. Most importantly, there's concerns for payroll, where they will potentially affect PEB's ability to collect premiums, and how this is going to affect, on the payroll side as well. So these issues have been escalated to LSI leadership, and PEB has been assured that the critical payroll issues will be resolved, and that there will be a successful go-live of the new system on January 1st. The updates I've received so far is that they're making progress, but I think it is prudent for the board to understand that there's, we're down to the wire and we are experiencing some very major concerns with this implementation. We do have a voluntary benefits update. Due to the mid-year eligibility system change from the LifeWorks and CoreStream product that we have today to Benefit Focus, a 2-week voluntary benefits special enrollment period occurred between November 8th and November 19th. And this period allowed members to enroll or cancel their voluntary products. So some new voluntary products were offered, some of them remained the same, and this allowed members to go in and make changes during that time. The below enrollment chart on page 3 reflects approximately 72% of the total 2,960 additional enrollments that occurred during this period. They were for brand new plan offerings, mostly with the standard, who replaced AFLAC for accident, critical illness, and hospital indemnity plans, as well as the new long-term disability plan that we offered in order to replace the benefit cut that was that came out of the last plan year benefit cuts. So this is now the long-term disability plan is offered on a voluntary option. This period also allowed members to create new accounts and become familiar with the system before it goes fully live at the end of the year, with 2,370 new accounts that were created and over 4,300 logins. So you can see on that chart we do have quite a bit of enrollment. It shows what people were enrolled in versus what changes happened through this enrollment period. We do have in the audience today, and as well joining virtually, both members, representatives from Benefit Focus and from LSI here as well, if the board has any questions for them.
Board members, questions? Ms. Biddleston.
Leslie Biddleston for the record. I have a question for LSI. According to Executive Officer Rich's report, it looks like there were some problems and delays with implementation that were not communicated in a timely manner. So my question to the vendor is, why were those issues not communicated more timely and rather communicated just before implementation? So that question is for the vendor. Thank you.
Like, so Scott Muir is in the audience, and I see his jacket there, but he's not in the room.
I don't see Mr. Muir from LSI. That's disappointing.
Is there anyone on Zoom that is available from either LSI or Benefit Focus that can speak to that?
This is Megan Hughes from Benefit Focus.
Go ahead, Megan.
Hi, and I just want to make sure for the question was for specific for the Smart 21, or was it for the benefit focus payroll?
Laura, for the record, I think sorry.
Go ahead.
I think the question was surrounding the delays and why the delays on the Smart 21 project were not communicated in a timely manner to the PEB project, and specifically since LSI oversees both of these projects. So they oversee the Smart 21 and they also hold the contract for the PEB implementation as well.
Okay. And probably would need LSI or would need Scott to pipe in on the overarching delay.
This is Laura Freed. Well, if there's no one who can answer the question, then I guess we'll have to table it. And, the board can always ask Ms. Rich and her staff to send a letter to LSI with the board's questions. For me, the question, and I guess this is more for PEB staff, the staff report says these issues have been escalated to LSI leadership and PEB has been assured the critical payroll issues will be resolved and there will be a successful go live on January 1st. What, in PEB's feeling, is a successful go live? What does that look like?
Laura Rich, for the record. First, I'd like to ask Nick, one of my staff, Nick Proper, would you mind going out there and grabbing Scott? He's probably on the phone out there. Yeah, thank you. And to answer your question, Chair Freed, so when there's an implementation, especially as complex and vast as the enrollment and eligibility system for PEB is, we always expect that there's going to be some hiccups, right? I mean, no IT implementation goes 100% smoothly. You're going to expect some issues. My expectation for a smooth go live is that members are able to access their accounts. They're able to enroll in health benefits, right? So in an insurance, and if they are new employees, and that they are able to make changes to their current enrollment as far as adding dependents or taking dependents off, et cetera, right? And then also that the payroll components are performed smoothly, and we have payroll deductions that occur in a timely manner and do not affect employees in a negative way to where, now their paychecks are affected because they do not have premiums taken out, or, we've got to take two out at a time, or, something like that. So it really, what I'm looking for is overall mitigation of any employee impacts to their paychecks and their ability to enroll in health insurance.
And how confident is PEB staff that all of those good things will happen by January 1st?
So I don't mind to put Mr. Proper on the spot, but he's the one who has been overseeing this project and is knee-deep in this, so I would like him to speak on that if possible.
Nick Proper for the record. Thanks, Ms. Rich. So at the time the board report was written, there's been multiple daily meetings since and a lot of new development work underway, which I feel productive. I feel we're in a good spot at this point. At the time of this report and at the end of October, we were all scrambling because of the shift from Smart 21 to continuing Advantage and legacy systems, which was out of scope for this implementation with Benefit Focus. That caused new files needing to be built this week and last week, and we're at a very good point. But this has also caused downstream effects for internal PEB processes with a lack of training and other components that we're not finished discussing until this week and next week, really.
This is Laura Food. Follow up, Mr. Proper. So have the benefit-focused files compatible with Advantage been built, loaded into Advantage, and tested? And if not, where are we in that process?
Thank you, Chair Fried. Nick Prober for the record. Yes, they have been built, they've been sent, and we are currently in the middle of testing these files back and forth with DHRM.
Okay. It appears we have the correct witness back in the room, so Ms. Biddleston, if you'd like to pose your question once again, that would be good.
Whoops. Uh-oh. Okay, sorry. I tried to destroy my microphone. Leslie Biddleston for the record, and this is from Executive Officer Rich's report directed to the vendor, who is LSI. So in Ms. Rich's report, there was some discussion about some problems due to implementation and the late or untimely communication of those problems. So my question is, why was there not more timely communication around the implementation with specifically around the benefit piece of this? I hope I said that right.
Yes, Scott, if you would please address that question. Thank you.
Hello, board members. Scott Muir for the record. I am the Executive Program Manager for LSI on both the Smart 21 and the PEB project. So to your question on communications, I just want to make sure I captured it right on why there wasn't more pre-advanced notice around the delay or the need to make the switch, if you will, to the Advantage system.
So as a longtime state employee, I mean, I understand the RFP process and I understand that you were selected as a vendor. So the question is, as you began your process as a vendor and you began to maybe identify some problems that, you know, it sounds like those problems were not communicated timely to PEB. So my question to you is, why was there a lack of communication, and what could you have done to do better, you know, because you have a January 1st implementation, right? Mm-hmm. So will we be able to make that on time? Mm-hmm. Is my question, and why there wasn't better communication.
Sure. And I defer to Nick as well. I believe when we started to understand that there was going to be a delay, let me back up one step. So the original plan was to couple the PEB project with the Smart 21 project as it relates to being able to use the Smart 21 payroll platform and not have to rely on the Advantage platform. And those project dates at the time both contracts were awarded and planned for all seem to coincide. I believe, and I'll go back through the records, I believe when we started to understand that there were going to be delays in the Smart 21 project, we did communicate that from the Smart 21 side. I think the OPM side started to communicate that. I believe we communicated that as well. We didn't know the exact delays at that point, and I think it was like midsummer to end of summer, but I'll get you the exact dates. But when we started to get closer to understanding that Smart 21 was not going to go live from a payroll perspective on January 1st as planned, we all worked together, Benefit Focus, ourselves, OPM, to then figure out how we could continue to make the January 1st go live successful. And as I think Nick pointed out, where we are right now is we've all come together as the parties. And I just checked this morning before I came over, the testing is going well. And as we sit today, not to say that there won't be things that will pop up, but the collective team, and I asked Nick to kind of chime in here as well, the collective team believes we are on track and we will make the January 1st go live for PEB. And we will have that full integration with Advantage for the time period that's required until Smart 21 is live on January 1st, 2022.
So as a follow-up, thank you. As a follow-up, having worked with vendors for a lot of years, unfortunately, I've experienced vendors that sometimes bite off more than they can chew. So they say they can do this, but they can't. Or they can, but it's going to take more time. So as a vendor of PEB, we would expect, or I would expect of any vendor of the state of Nevada to be very communicative and just say, we've got some issues here. Maybe it's just with a piece of it, to be more proactive because this affects a lot of members. And we want to make sure that, like Executive Officer Rich said, that we don't want to take 2 or 3 premiums at once because the payroll system isn't working.
Correct.
Or something like that.
Yeah.
Because everybody's hurting. Our members, we've heard it. So it's just, we would expect our vendors to be more proactive rather than less proactive. So untimely communication doesn't make me happy.
Okay.
So anyway, but so thank you for your answer, and we'll look forward to a successful implementation on January 1st.
Great. And if I could just follow up, I just want to acknowledge that, and that we have put remediation steps in place, both on the Smart 21 side and the PEB side, to have that effective regular communications. And I would hope that Laura and the team would all acknowledge that we've tried to mitigate that. So thank you.
Mr. Barnes.
Yes, for Executive Officer Rich, Jim Barnes for the record. Will the next open enrollment allow members to buy long-term disability insurance without a medical review?
Laura Rich for the record. So long-term disability is offered as a voluntary product, and so I'm going to have to defer to Nick Proper because he is much more familiar with the terms of these products than I am.
Thank you, Ms. Rich. Nick Proper for the record. To be able to be qualified for a long-term disability plan or other life insurance voluntary benefits, they must be approved through an evidence of insurability and medical forms. We cannot bypass that requirement, and that is a requirement of the carrier.
Okay, thank you.
This is Laura Freed. I have one final question for PEB staff. Does the contract with LSI and Benefit Focus contain penalties that will be assessed if on Go Live the wrong premium is deducted from a member's paycheck, or the data transfer doesn't work, or one of those other things that we are afraid of happening, i.e. the opposite of what Ms. Rich described as a successful rollout happens? And what are those penalties?
Laura Rich for the record. That is a very good question. I would have to actually pull up the contract and look specifically at those.
That's okay. You can get back to me.
Okay.
Okay, board members, this is a discussion item, not an action item. So if nobody has any more questions, comments, we can move on. All right, so we'll move to agenda item 8. And here, I want to caution that if there are detailed questions, before I throw it to Ms. Eaton, if there are detailed questions, we may have to go into closed session. And so, depending on the questions, I may call timeout and tell broadcast that we need to go into closed session.
So Laura Rich for the record. Ms. Eaton usually gives this report, and she is on, but she is on vacation, technically, so I don't want to make her do any more work than she needs to do, so I told her I would do the report for her. So 8.1, you guys have seen this. This is just the contracts overview. This is the table that's included in this report typically. So I'll just move to 8.2, which is new contracts. The PEB board approved the solicitation for a TPA, third-party administrator, to include TPA medical, dental, and national network, as well as a statewide network and subrogation services on January 28th of 21. At that same board meeting, the separate solicitations for telemedicine, a shopping comparison tool, second opinion services, and HSA and HRA administration services, with those contracts, with the contracts being held by the TPA. So the RFPs were released for the TPA, HSA and HRA administrator, second opinion services, telemedicine services, and PEB staff have successfully negotiated contracts for all of these. So the first one, 8.2.1, is the TPA. On April 26, 2021, the Public Employees Benefits Program released the proposal for the TPA. What we were looking at here is to acquire a health and dental benefits administrator that would be a strategic partner in providing the services in the scope of work. And so we looked at requiring an out-of-state medical network as well as a optional in-state network as well. PEB required that the winning TPA agree to hold contracts for all ancillary services, which is the HSA and HRA administration, shopping tool, and the second opinion and telemedicine services. So vendor responses were scored based on minimum qualifications and critical items, technical, customer service, financial, network access, and member disruption, as well as finalist presentations. On June 2nd, PEB received 7 proposals in response to this RFP, and the evaluation period began on June 25th and ended on August 9th. The evaluation committee was included 2 PEB board members and many other subject matter experts as well. UMR received the highest score by the evaluation committee, and PEB has successfully negotiated a contract. And just to be clear, although HealthScope Benefits is the incumbent, they were bought out by UMR, and so basically it's UMR is not the incumbent, but is the closest to it, really. And so it's not, the transition would not be really, they've got all our data, we would have the same account reps. And so it's, even though UMR submitted the proposal, it's still using the HealthScope Benefits staff with some changes, technology changes and things like that. So some of the highest scoring areas by the evaluators were the innovation and delivery system, network access and management, account management, customer service, website and mobile app capabilities, communications, the finalist presentations, and vendor experience. So UMR will be the new vendor for PEB for TPA services. However, since UMR is the parent company to the, as I said, to HealthScope Benefits, the transition is expected to be overall less disruptive for members and will require minimal implementation to move on to that product. And as part of the proposal, UMR submitted 2 network options, one using the incumbent network, which is Aetna, and another leveraging Choice and Show. The Aon analysis shows that minimal in-state disruption and significant cost savings with the latter. So additionally, by leveraging the proprietary networks, members were able to take advantage of self-service technology in the UMR portal that is currently not available through PEB today, such as shopping comparison tools, interactive provider searches, and insight into prior authorization requests. So in order to use the Choice and Show networks and have access to the above, UMR also requires utilization management and case management services to be incorporated into this contract, and currently PEB contracts with American Health Holdings for these services. So that contract is due to expire on June 30th of 2023. So PEB must issue a no-cost termination in order to end that contract a year early. Additionally, PEB will also need to issue a no-cost termination to Aetna, who currently holds that contract for the in-state network as well. Although this contract was recently awarded, because, and just to give you a little bit of background, so typically when the industry standard is to RFP for a TPA that comes with a network, right? And so it's a kind of a bundle deal. Typically, organizations don't go out to bid for a TPA and then a network because those two are so closely associated that usually it comes as a package deal. PEB was set up in a way where we were put in a place last year, or 2 years ago actually now, that our contract was expiring, and so we had to go out to bid in order to secure a new network. But we wanted to fix this by at least allowing a TPA to propose a network and taking it as a bundle deal if it were a situation where it were a benefit to PEB. And so that is the situation here, and that is why UMR bid using both network options. So the effective date of the contract is anticipated to be December 14th, 2021. That's upon Board of Examiners approval. And it's through June 30th of 2028. Services and fees are expected to begin on June 1st of 2022, and the contract maximum is $62,789,120. UMR has agreed to hold contracts for the telemedicine provider, shopping comparison tool, and second opinion services vendors that are chosen, and has assisted in contract negotiations with those winning vendors. So the shopping comparison tool is also, since it's included as no cost with this proposal, it is an integrated service of the TPA contract with the use of that selected network. So UMR also bid and was selected as the winning vendor for the additional ancillary services, second opinion services, and telemedicine services. So second opinion is UMR. They are partnering with 2nd.MD. They are also partnering with Doctor on Demand. Those are the two current services that we use today, so there would be no changes to that. And the contract max does include the fees associated with those services. The recommendation here is to ratify and approve the Evaluation Committee's recommendation to contract with UMR for third-party administration and associated services beginning July 1st, 2022.
Okay, thank you. My thanks to any of the board members who are on the TPA Evaluation Committee, because the TPA RFP is no joke. So thank you, whoever you are. Questions, board members? Member Kelly.
I don't have a question, but I do wish to make a statement, but I'm not sure it's appropriate in public forum.
Oh, I see. All right. Well, we can go into closed session. I wonder if there will be other such statements that we should cover on the HSA Bank contract and the amendments. Okay. Well, with that, LCB Broadcast Services, if we could go into closed session, take the time you need to arrange that, I'd appreciate it. And everybody who is in this room who is not purchasing division staff or PEB staff or the actuaries, I don't think, unless it's okay to have the actuaries. Everybody else gets to leave for the time being.
Do we want UMR reps in here as well, or
We
no?
can have you. Why not? I'm generous.
Okay.
Oh, I'm sorry. No, purchasing says no. We're negotiating with them. Okay, got it. Welcome back, board members and audience and everybody. Broadcast services, do you need a couple of minutes to continue to assemble everyone who wants to be on the Zoom or on the phone?
Chair, broadcast is ready and we're rolling, and we're ready whenever you are.
Okay. Well, with that, I'd like to it's 2:03 p.m., and I'd like to call the open PEB board meeting back to order. We went into closed session. We were discussing item 8.2.1, the recommendation to ratify and approve the evaluation committee's recommendation to contract with UMR for third-party administration and associated services beginning on July 1st of 2022. We had a productive discussion in the closed meeting, and without further ado, I would accept a motion to approve the evaluation committee's recommendation.
So moved.
Thank
Michelle
you.
Kelly for the record.
Thank you. Do I have a second?
I'll second Leslie Biddleston.
Got it. Thank you. All right. It's been moved and seconded to ratify the evaluation committee's recommendation for UMR as the TPA vendor. All in favor signify by saying aye.
Aye.
Aye. Any opposed, say nay. Okay. Motion carries. Thanks. Real quick, let's go on to 8.2.2, the HSA Bank.
All right, Laura Rich for the record. So on July 1st, 2021, the Public Employees Benefits Program released an RFP for a health savings account and health reimbursement account, HSA HRA Administrator Services contract. So the objective of this RFP is to acquire an HSA and an HRA administrator that will be a strategic partner in providing the services that are included in the scope of this RFP. I will say that with so many contracts out there, PEB actually had made a little mistake, and we forgot to include that in the RFP, that the contract holder would be the TPA. And so in this contract, typically this would have been through the TPA as was identified in the TPA RFP. But when we released this RFP, it was just not included. That was our oversight. And so when HSA Bank got awarded this contract, we owned our mistake and really just said, okay, we're going to, instead of having this go through the TPA contract, it will be a direct contract with PEB. So it is unfortunate, but not a huge mistake in the grand scheme of things. So the vendor responses were scored on minimum qualifications, technical, customer service, financial, and then some finalist presentations. And on July 30th, PEB received 14 proposals in response to the RFP. The 5-member evaluation committee included 2 board members and other subject matter experts, and HSA Bank received the highest score by the evaluation committee. PEB has successfully negotiated a contract. HSA Bank will be the new vendor, and the transition is expected to be rather smooth. The effective date of the contract is anticipated to be December 14th, 2021, upon BOE approval through June 30th of 2026. Services and fees are expected to begin on June 1st, 2022, and the contract maximum is $0. So this is a $0 contract. It was a $0 proposal that was proposed. And so the recommendation here is to ratify and approve the evaluation committee's recommendation to contract with HSA Bank for the HSA and HRA administrator services beginning July 1st, 2022.
Board members, any questions, comments? Okay. I'll accept a motion to ratify.
This is Betsy. I move we ratify the HSA Bank
Do I have a second?
April Kern, I'll second.
Great, thank you. All right, it's been moved and seconded to approve the Evaluation Committee's recommendation to contract with HSA Bank for health savings account and health reimbursement accounts beginning July 1st, 2022. All in favor signify by saying aye.
Aye.
Aye. Any opposed, say nay. Okay, motion carries. Moving on to 8.3 contract amendment ratifications. Since we just ratified the UMR contract, I think that makes 8.3.1 Aetna and 8.3.2 American Health Holdings pretty quick and simple. They need to be terminated. So I would accept a motion to approve PEB staff to serve term notices on Aetna and AHH in one motion, if that's okay.
April Kern, I'll go ahead and make that motion.
Thank you. Do I have a second?
Linda Fox for the record. Second.
Thank you. Okay, it's been moved and seconded to process contract amendment ratifications to term Aetna and American Health Holdings, both effective July 1st, 2022. All in favor signify by saying aye.
Aye.
Aye. Any opposed, say nay. Great, that carries. All right, moving on to 8.3.3, Aon Consulting.
Laura Rich for the record. So previously, the PEB board had approved staff to move forward with a project involving the Patient Protection Commission and Medicaid to assist the Peterson-Milbank program for on a project regarding sustainable healthcare costs. Previously, that contract, the original cost of that project was going to be $150,000, and the board did approve that with potentially it getting cost shared through the Peterson-Milbank funding. As we've worked through this, we've been able to identify other sources, data sources, and Aon has actually dropped the cost due to the ability to leverage some already existing processes that were in place already through HealthScope benefits. So the new cost of this project is $50,000, so we were able to save quite a bit of money on this one. As a result, we are no longer requesting the additional outside funding. The reality is for $25,000, it's a lot of work for PEB and the state and Peterson-Milbank Foundation to go through to actually receive those funds because of the contracting processes that are in place. No one really is equipped to receive it. And so because it is now such a low amount and it does help PEB, we are just assuming the responsibility ourselves, and the contract amendment is now $50,000 rather than the $150,000. So I will stop there for questions.
Any questions?
All right.
Okay.
All right, and so the recommendation there is obviously to approve that one. The next one is LSI Consulting. Again, this is a reduction. On September 30th, 2021, the board approved staff to complete a contract amendment with LSI to begin services and payments regarding their ability to manage the COBRA responsibilities of the program. And so we had to add additional work order authority. After some additional conversations, LSI did agree to revise the cost of the COBRA management being offered, and so the original increase to the contract authority the original amendment to increase contract authority by $1.354 million was withdrawn, and it's now revised to only increase it by $479,000. Approximately. So the recommendation here is for PEB to the PEB board to authorize staff to submit the updated contract amendment between PEB and LSI for the COBRA services in the fee schedule and increase the contract maximum.
Okay, board members, I think I'll do the same thing since we've got 8.3.3 and 8.3.4 both scaling back the amendments. I'll accept a motion to approve staff recommendations for both of those at once.
This is Leslie Biddleston, so moved.
Thank you. Do I have a second?
Betsy Aiello, second.
Thank you. Okay. Motion is to approve staff recommendation for 8.3.3 and 8.3.4. All in favor, say aye.
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 Aye. Aye. Opposed, say nay. Great, thank you. And last but not least, contract solicitation ratifications, except this seems to be the opposite.
So the PEB board approved Laura Rich for the record, the PEB board approved the solicitation for the shopping comparison tool. For those of you who aren't familiar with it, we currently use Healthcare Blue Book for those contracts that are to be held by the TPA. But as we got through the TPA RFP and the negotiations for that contract, we saw that the UMR offers a comprehensive shopping tool that is part of their services and part of the member portal that the member can access and use. And so since this is already part of the service with no extra cost, it just did not make sense for PEB to pursue this contract or to release this solicitation. So what we're asking for here is for to allow PEB staff to cancel that solicitation and not move forward with the shopping comparison tool RFP.
Okay, do I have a motion to approve PEB staff to cancel the solicitation? Mr. Verducci so moves. Any second? Thank you. Ms. Kelly? All in favor signify by saying aye.
Aye.
Aye. Aye. Any opposed, nay? Motion carries. Okay, thank you. With that, if I'm not mistaken, we are back on our second public comment period, agenda item 9. And so is there any public comment here in the room in Carson? Seeing none, I will turn it over to broadcast to see if there is public comment on the internet.
Thank you, Chair. To participate in public comment, please press *9 or raise hand in the Zoom call to take your place in the queue.
Hello, are you able to hear me?
Yes, we are.
Oh, thank you. Good afternoon. My name is Janelle Woodward, JANELLWOODWARD. Again, I'm a state employee representing AFSCME state employees. I just want to add that we are very disappointed in the decision to go with option 2 over option 3, which was heard so much in the public comment in the beginning of the meeting. I want to publicly thank Mr. Verducci and the couple of other people who have truly represented the state employees and listened to the comments from the public and pushing for us to get back what has been taken away. This is a serious issue that needs to be known. And I know there are hard decisions, but we just appreciate the support that we get from them. Thank you.
Thank you. Next commenter.
If you have recently joined the call and would like to participate in public comment, please press *9 or raise hand in the Zoom call to take your place in the queue. Chair, the public line is open and working. However, there are no callers wishing to participate at this time.
Okay, thank you very much. And thank you for all your hard work today, Broadcast Services. It's been really, really appreciated. With that, I believe we have reached the end of our agenda, and it is time to adjourn the meeting. So it's 2:18 p.m., and the PEB board is adjourned. Thank you, everybody, for your testimony and help today.